Sorry.
Cow meat.
Sorry.
Cow.
Okay.
Half kilo.
Half kilo.
Yeah.
عليكم السلام.
وإذا
You are making a tap to continue.
On mute, sir. You know the video this how this thing no dey.
I don't come out in
But I've joined that meeting now.
Yeah, it's supposed to.
Oga Ali, una don dey join ba?
In our network.
Èmi náà o, network ni. Oga Ezike don dey there. Ndego Solomon. Oguntoke.
I didn't do it.
This one automatic because I know.
Wetin una dey talk now? Should be automatic.
Yeah, one man, you cook like this. And the same thing. She see me, but I don't come. See my name, don't show. See, they see
Okay.
one house here. Tap to unmute, I have unmute.
But your name don't show here.
What's going on in this group now? I don't understand. I need that idea to let me have you drink am.
What is the problem of the network, please?
Good morning, everyone. Please, please exercise a little patience. The facilitator will soon join to start the presentation of today. Thank you.
Good morning, everyone.
Good morning, sir.
Morning, sir.
I'm good.
Good morning.
Sorry, I joined late. I was having a bit of problem with my system, but it's fixed. Can we start now if you guys are ready?
Good morning, sir. Yes.
Good morning.
Good morning, sir. Yes, sir.
Yes. All right.
Good morning, sir. Yes, sir, we
morning.
can start, sir.
All right.
You're most welcome, sir.
Thank you. Is my slide visible?
Yes, sir.
So we're going to be talking about getting started with exercise therapy. Actually, I'm approaching this presentation in two perspectives. One is therapeutic aspects and to some extent, general exercise therapy. It's going to be a lot elementary. The starting session will be elementary. It's going to be like a reminder to quite a number of things that you are aware of. That's the first session. Then in the second session, we're going to go more advanced. So let's get started. Now, the content of this presentation involves introduction, pre-exercise screening, the concept and practice of stretching, warm-up and cooling down, flexibility and range of motion exercises, aerobic conditioning, strengthening exercises, balance and coordination, functional performance in uniform men, and we conclude after that. So the first session that we're having now is going to involve from the introduction to flexibility and range of motion exercises. So this is the first session. The second session will start after one, I think around 2. we're going to be engaging in aerobic conditioning, strengthening exercises, balance and coordination exercises, functional performance in uniform men, and we conclude from there. Now, as a matter of introduction, first of all, we need to appreciate what is actually exercise, what is physical activity. These two terms are often used interchangeably. You realize people may say I'm physically active, and probably they are referring to performing exercise. And sometimes you hear them saying I'm performing exercise, and so on. So sometimes you realize some people use the word physical activity, some people use the word exercise. But technically, as well as clinically, the two are not the same. When we talk about physical activity, it actually involves any form of activity that involve bodily movement. Any form of activity that involve bodily movement, referred to as physical activity. Now, it could be walking from your room to another room. It could involve going from one place to the other, carrying some luggages and all that. All those are classified as physical activity. And of course, because of this, that is why when we say somebody is physically active or physically inactive, and we say somebody is sedentary. Now, when you use these two terms, sedentary lifestyle and physical inactivity, you tend to have a situation where people confuse them to mean the same thing. If somebody is physically inactive, we can say the individual is sedentary. But interestingly, these two are not equally the same. Sedentariness is different from physically having low physical activity. Why? Because somebody may be, in quote, in terms of definition of physical activity, the individual may be considered to be physically active. But then when it comes to definition of sedentary, the individual may be considered to be sedentary. Why do we say that? Because sedentariness actually refers to a situation, the number of hours or time an individual spends doing nothing. So you may be physically active by, let's say, academically physically active, or let's say in terms of definition of physical activity, which means performing certain level of physical activity to a particular extent. Now, if you accomplish that, for example, I have my physical activity measurement for personal one is for me to have 1,000 steps in a day. This is what I set for myself. So if I accomplish 1,000 steps in a day, which I can do probably from within an hour, I mean 10,000 steps in a day. That is what I define for myself. If I'm able to take 10,000 steps in a day from the definition of physical activity, then I can consider myself to be physically active because I've got my 10,000 steps in a day. But then the whole of the day, I may remain static. I may remain idle. And that is being sedentary. So sedentariness is the amount of time, the duration somebody spent doing nothing. While physical activity, I mean, physically inactive is when it falls below the recommended demand for physical activity. So now, when we now put this together and to separate between exercise and physical activity, we mean every bodily movement is counted as physical activity. While what is exercise? Exercise is actually something that is structured, something that is defined, something that is intensive. When this structuring is included before an individual conducts an activity, then it is exercise. So I just feel I should make a bit of clarity in that. Now let's talk about the full introduction. Therapeutic exercise is recognized as a central element in most physical therapist procedures of care. Now, previously, therapeutic exercise is only given when an individual is considered to suffer a particular injury or have certain limitation, probably a limitation in range of motion, let's say being bedridden for a long time because of cardiovascular disease challenge, respiratory conditions and all that. So until an individual is discovered to have one of these challenges, that is when therapeutic exercise is recommended in the past. But contemporarily, therapeutic exercise is considered something that is not only prescribed because of ill health or because of one condition or the other, it is also considered as part of preventive health care. So its meaning has become elaborated, bigger than it was in the past. So it covers both preventive approach as well as curative approach. Curative approach as well as rehabilitation. So it has these three components. It has preventive, it has curative, and it has rehabilitation aspect. So currently, in terms of defining therapeutic exercise, we encompass preventive aspect of it, curative aspect of it, as well as rehabilitation. These two colleagues, Brody and Hall, regarded therapeutic exercise as a systematic performance or execution of planned physical movements, postures, or activities intended to allow the patient or client to accomplish the following. Number one, to remediate, and that's why I talk about issues of prevention, remediate or prevent impairment. We are anticipating that somebody, for example, somebody who came from a family of diabetic, where you have history of diabetes, and it is known that diabetes can actually be genetically inclined. And for this reason, the individual decided to get himself involved in consistent physical activity or therapeutic exercises such that he delays or even prevents the occurrence of diabetes in that individual. So he's remediating or preventing the impairment that may occur due to diabetes. It could also be prescribed to enhance function in a person. It could be used to reduce the risk of the condition. For example, an obese family, people who are trying to prevent themselves from obesity and all that. It could be used to optimize overall health. You even want to improve your level of health, you can use therapeutic exercise. It can be used to enhance fitness and well-being of an individual. So when exercise is prescribed for the purpose of any of these 5 reasons, then it is considered as therapeutic exercise. The physiotherapist examine for a physiotherapist to actually recommend therapeutic exercise. He does not do it without, and the physiotherapist distinguishes himself or herself from other, let's say, if we call it professionals, or let's say other people that are involved in the prescription of exercise. The physiotherapist distinguishes himself or herself by first being an individual who examines the individual to know the requirement for the exercise for that individual, who diagnoses what is actually the condition the individual is coming with, who selects specific form of exercise or select specific patients that can be considered for certain type of therapeutic exercise, who now prescribe based on his examination, diagnosis, as well as selection of patient, prescribe an exercise that is appropriate for that individual, and later implement or perform the exercise activities when he or she, when his or her investigation or findings or diagnosis and prognosis indicate the use of therapeutic exercise. So it is, therefore, this statement is actually saying that it's actually possible during the periods of examination, diagnosis, investigation, or whatever you call it, the therapist may conclude that based on my findings, this individual is not qualified for therapeutic exercise. Based on my findings, these are the type of therapeutic exercise I'm going to administer for this particular category of patients. So unlike what you see, for example, I recall I've had encounter with a number of my patients that at the course of our discussion, probably somebody who has osteoarthritis of the knee, or somebody who came with the case of diabetes, hypertension, and all that. And I was like, why? Oftentimes we find out that these patients are referred late. And of course, because the doctors or physicians usually place them on medication for a long period before they later refer them to physiotherapy. And I often ask the patients that, what actually, why were you delayed? Why are you just coming? And they'll say, oh, I'm only referred now by my physician or referred by the doctor. And did your doctor tell you about exercise? Yes, he told me to be exercising. He told me to be active. But then ask him, what amount of exercise did he ask you to do? What quantity of exercise did he place you on? What are the specific exercises he asked you to do? You realize that the doctor prescribed nothing, only tell the patient to be active. Why is the doctor making such prescription? It's because it's not his field. The people that are specifically trained to examine the patient for the type of exercise the patient will need, to diagnose the patient, to know whether the individual is qualified for exercise or not, to select the type of exercise the individual will need, and to make prescription of that exercise are trained physiotherapists. So this is what distinguishes you from other professionals who may make an attempt towards recommending exercise for patients. When you now find yourself as a physiotherapist, but all you do is to just ask patient to exercise without conducting examination, without being able to diagnose what is wrong with the patient, without selecting what type of exercise the patient should engage in, without making proper prescription of the exercise, then you are aligning with those who are not trained, or probably quacks. So you must be able to distinguish yourself, to have the quality, the required training to be able to do proper examination, to be able to diagnose the condition, to be able to select the type of exercise, and to be able to make the right prescription of exercise for the patient. There are various types of therapeutic exercise approaches, including the following, that can be recommended for patients. We have aerobic and endurance conditioning and reconditioning exercises, which I said will be coming in the next session of this presentation. We have balance, coordination, and agility training. We have body mechanics and posture awareness training. We have muscle lengthening. We have, which is what some people call muscle stretching, range of motion techniques, gait and locomotion training, movement pattern training, or strength, power, and endurance training. These are all forms of therapeutic exercises that we can recommend as well as prescribe for our patients when our diagnosis suggests that we should go ahead with these prescriptions. Therapeutic exercise should be planned to target clients to patient individual goals that provide patients or clients with the ability to achieve optimal functioning in home, work, job, school, play, and community/leisure activities. Now, oftentimes one of the things that we do when it comes to prescription of exercises is that when a patient presents to us, we go ahead and based on our examination and commence prescription, recommending specific exercises, putting a patient to certain types of exercises. But one thing that is wrong with that is that the patient is never involved in the decision-making of the type of exercise to be recommended. So in this regard, you realize that the patient, probably that is not what actually the patient is looking for. I recall, I think in one of my presentations sometimes ago, I was telling people that I had a patient, and this patient actually came to me, and is a stroke patient, and this patient was having problem with ambulation. And immediately I finished, examining this patient, I have specific exercises that I prescribe for the patient. But at the point, the patient was like, doctor, let me tell you one thing. I'm not bothered about walking perfectly, but I have certain level of sensation that is radiating down to my lower extremities. This bothers me more than the exercises you are giving me. If you can take away this, even if I cannot walk properly, I don't care. So now I got to understand that the mistake I made in such a case is to focus on what I think the patient needs without involving the patient in the prescription of the exercise. Immediately, this patient talked about this. I have to think of other compensatory management to add to the therapy of ambulation before I continue with the management. So when a patient approaches you, the key thing you need to focus on is not just what you think as a therapist, but as well, what does the patient want? What is the goal of the patient? What does the patient want to achieve? You have a case of a sport injured, an athlete who is injured. And his major focus is, I don't want to lose my job. I want to get back to active sporting as fast as possible. Now, that particular goal that the patient is looking for, you must factor it into the prescription of the exercise so that the patient can be able to achieve that. You have a school child who actually suffered certain injury and is a playful type of a child. And by the time you withdraw him from play, he may actually have some emotional challenges. So factor in the need of the patient. What are you missing? What do you have as a problem? What is your major challenge? Ask such questions. Pose such questions so that the patient will be able to tell you exactly what they want and factor that their need or their goals into the plan of the treatment. This will help you in delivering the therapeutic exercise as perfectly as possible. Now, to achieve this goal, to achieve the goal of the patient-oriented goal, the therapist should focus on the following: providing comprehensive and personalized patient management. We say the management should be what? Comprehensive, elaborate enough. And it should be what? Personalized. It should be patient-centered. Now, two patients may actually approach you, or even more, may approach you with a condition that is seemingly the same. But that does not mean that what they actually are targeting is the same. Focus on individual need and factor those individual needs into your therapy. That will actually help you to achieve more in your therapeutic plan. Then you should have clinical decision-making skills. You must have a good clinical decision-making skills. What do we mean by this? To take a decision for what the patient needs. To develop a good clinical decision-making skills, you need the following. We've mentioned some here. Number one is, do you have good ability, excellent ability to be able to investigate the condition? Can you be able to diagnose the condition? Can you be able to recommend the adequate treatment plan? Can you arrange an adequate treatment plan for the patient? Can you execute the plan? And above all, do you have evidence for the recommendation you are making for the patient? Which is to say, evidence-based practice must also be involved. So when you put all these together, your clinical decision-making skill will actually be so excellent that every patient will be very glad to pass through you. Implementing a variety of therapeutic interventions that are complementary. Sometimes even though exercise is what we are trying to recommend for the patient, and we know exercise is required or is recommended for the condition, it may not be possible sometimes to initiate treatment with exercise. depending on the presentation of the patient. A patient who have significant level of muscle spasm, where every movement is actually causing pain, there is no way you can start management of that patient, even by simple massage. You may actually need to have complementary management, such as heat therapy, cryotherapy, and many other forms of therapy to lessen the level of pain before you introduce your therapeutic exercise. So you must have the know-how of what complementary therapy do you need to add to your treatment before introducing therapeutic exercise. So this is very important, and it is also part of what you have to know in your clinical decision making. What am I going to start with? Am I going to go into the exercise directly, or do I need complementary therapy before I introduce therapeutic exercise? If you don't have good clinical decision making, you are actually going to get it wrong. Again, in your therapy, do I start with passive stretching? What am I going to start with? Am I going to start with passive activity? Am I going to start with active activity? Do I need to go into resistant exercises? What type of treatment am I going to start with? Those are also key in your clinical decision making. Followed by active, to use new mobility in a functional manner. So what form or what particular therapy intervention is going to aid proper implementation of your therapeutic exercise? Promote patient independence whenever possible through the use of home training. Now, currently, one of the main thing is that you realize that sometimes a patient comes to the hospital, you manage the patient, and you discharge, and you ask the patient, particularly those that are coming as outpatient. After they've gone home, they return with either similar level of pain or limitation in range of motion, or there is even worse conditions. Now, why do we have that? A number of times physiotherapists only see patients without telling them how to continue with the therapy at home. I often give this example. There is no particular, it's not usually possible with the number of patients you have in front of you to say that you are going to be able to treat each patient for up to 1 hour. And the example I often give my patients is, get to know that you're coming here is like you are coming to school to learn what to do. The therapy I'm going to give you is a guided therapy for you to continue at home. And the reason why I'm telling you this is because how many hours do you spend coming to this place? Somebody will say, I spent 2 hours before I got here. Somebody will say, I spent 2.5 hours before I got here. And I say, how long do I usually treat you? Oftentimes they will tell you 30 minutes, 40 minutes, and hardly do you see anybody that will mention up to 60 minutes. Let's even assume it's up to 60 minutes. And I will say, at the 2 hours you spend before coming here, let's even make it 3 hours. Before reaching here, you spend 3 hours. Add the 1 hour I use in treating you, making 4 hours. How many hours will it take you to go back home? 3 hours. Add it together. You're going to have a total of 7 hours. And I said, how many hours do you have in a day? And they will tell you you have 24 hours. So take out 7 out of the 24 hours. What do you have left? They will tell you we have a total of 17 hours. And I say, where would you be in these 17 hours? Most of the conditions that we see are chronic conditions. A number of them will tell you that I will be at home. And the question is, what are you doing at home? I'm doing nothing. And you remember I talk about the sedentary lifestyle. Now, if they are doing nothing at home and they are spending 17 hours just for that day, do they come to the hospital every day? The answer is actually no, which means aside from the 17 hours of the day they came to the hospital, they have several 24 hours on which they are not doing anything. Now, for you to make sure that your therapy is actually coming out, you are able to get a result, is for you to be able to give them as many home programs that are feasible for them to perform. And I emphasize feasible, because sometimes we prescribe home programs that patient cannot do.
patient will not be able to conduct it. Family members cannot even assist them. So when you make such prescription, you are only wasting your time because nothing can be achieved. So the key thing is, because patients spend more of their time at home, home program is a necessity for every patient that comes for physiotherapy. Because why? Most of the patients you are going to see are going to come with chronic condition. If it is not chronic, why does he have to come literally every week? Sometimes fortnightly. That indicates that the condition you are seeing, even if it is a finger, an injury to the finger, it is a chronic condition. So if he's going to come back because of this finger, definitely it's a chronic condition. If it is a facial palsy, it is a chronic condition. If it is back pain, it is a chronic condition. So definitely, literally every patient that is coming for physiotherapy needs certain level of home programs. So if you don't make such prescription, you are actually not really helping this patient, because they spend the bulk of their time at home doing nothing, and therefore your therapy remains the same because you did not make proper prescription of home program. Sometimes we could actually complementary treatment like the heat therapy, like the cold therapy, we can give them these to do at home as well. A number of times we are thinking of quackery and all that. There must be a way that you can pass your information. That patient will be scared of telling another person to do the same thing because he was asked to do it. Simply, let's say, for example, I ask you to use cryotherapy at home. And I tell you clearly that cryotherapy we can have frostbite from cryotherapy. And frostbite is often more difficult to manage than blisters. And it is more difficult for us to manage than simple pain. Simple injuries. Do not recommend this to another person. This is specifically for you. Some patients may even have bad condition when you recommend this. Give them information that will make them to be careful of recommending this to other patients when they get home. So these are key things, but it doesn't mean you cannot ask them to do it. You can actually ask them to do certain things. So give them home program, and home program would actually complement your management. So let's talk about pre-exercise screening. Now, this pre-exercise screening is not usually a direct property of therapeutic exercise. It is a direct property of preventive therapeutic exercise. I hope you'll be able to understand what I mean by that. When we want to use preventive therapy, we use a pre-exercise screening. Sometimes when equally we are having clients that the condition they are bringing in is not injury related, it's probably chronic condition like hypertension, like diabetes, like cardiovascular diseases, we do pre-exercise screening. And pre-exercise screening is so necessary in many of the cases we are going to be seeing or we are seeing. Unfortunately, a number of us are very careless when it comes to pre-exercise screening. Probably because our country allows stupidity. I'm sorry to use that term. Or negligence, let me use negligence. Where even if you kill a patient, you go scot-free, nothing will happen to you. And nobody will start investigating whether it is your practice that actually killed that patient, whether it is your negligence that actually killed that patient. They just say it is destined. Unfortunately, he was trying to do exercise, and imagine, in fact, other patients are doing it, they are okay. Unfortunately, this person just started. Before you know it, he slumped and died. Even if we do not do this exercise, it's possible, even if it is at home, since it is destined, this person may even die at home. It is just that, unfortunately, God Almighty say that this is the place the person is going to die. This is completely unacceptable scientifically and clinically. We are not saying that a patient may not die when you do the right thing. But first of all, do the right thing. If the patient died, it's destined that the patient is going to die. But you did not do what is right, and the patient died, and we are still saying it is the making of the Almighty. We are so lucky in this, let me say, in this country, that we are still living in the olden days, where patients are not taking us to hospital to, for us to be charged for negligence. So we're going to be talking about exercise screening. Why? Because it is one of the most important things that every physiotherapist must be aware of and be able to equally conduct it. Pre-exercise screening is used to identify people who may have medical conditions, which put them at high risk or higher risk during physical exercises or activities. Remember, I said identifying people who may have medical conditions. Now, they may even already have the medical condition, but we could do this screening to know their level of readiness to be able to partake in to partake in exercise. So it is not only saying that when somebody has never done exercise before, that is when we do pre-exercise screening. No, even if somebody is already regular in exercise, but he has stopped exercising for some time, we can do pre-exercise screening. Or when a patient presents with a condition, for example, a patient is sent to you that this patient is diabetic, please place him on exercise. You must do exercise screening. Or this person presents with hypertension and they ask you to prescribe exercise. You must do the exercise screening. This patient is obese and you are asked to put this person in exercise, prescribe exercise for this individual. The individual must go through pre-exercise screening. So pre-exercise evaluation serves as a bridge between risk stratification, the fitness, and clinical exercise testing concept. When we talk about stratification of risk, there are levels of risk that is already enshrined in practice. You need to identify which level of risk is the patient bringing in. What is the level of fitness of the patient to know the type of exercise you are going to prescribe? In the risk stratification, risk stratification is basically focusing on whether the person is even qualified for exercise or not. Now, fitness is measuring the level of fitness of the person for us to know the level of exercise we can give. Clinical exercise testing concept involve both the risk classification as well as level of fitness. All these must be put together before you finally prescribe an exercise for a patient. The process by which individuals are assigned to one of these risk categories called risk stratification, and is based on presence or absence of known cardiovascular, pulmonary, or metabolic diseases. So these are the risk stratification levels. An individual could have low risk, that if he perform exercise, he has low level of risk. We are not expecting too much of a problem when that individual is involved in an exercise. So they say, for this individual we have is asymptomatic, less than 1 risk factor. It has minimum less than 1 risk factor. We are going to be talking about the risk factor as well. Moderate risk, asymptomatic, more than 2 risk factors. He has more than 2 risks that may actually develop due to exposure to them. We have high risk. Dr. Samani, are you online? Can you mute those individuals, please?
Well, the problem is some of you are just coming now. Some of you are just coming now. I'm not saying you will not get, but some of you are just coming now.
High risk, symptomatic or non-cardiac, pulmonary, or metabolic diseases. So when we say people that are at high risk, and you must be very careful in prescribing exercise to them, are those individuals that already they presented with cardiac diseases or pulmonary diseases or any form of metabolic disease. So already these individuals have established conditions before coming, and therefore they are categorized as people that are at high risk of having problems when they are exposed to therapeutic exercise. Now let's talk more about this. The American College of Sports and Medicine risk stratification level gave this further description of those individuals with low, moderate, and high risk. Individuals like men that are below the age of 45, women that are below the age of 55 of age, who are asymptomatic and meet no more than one risk factor, they are considered as low risk. So if persons are below the age of 45 as men, or women at below the age of 55, and they have no more than one risk factor, they are considered as low risk. Moderate risk are those individuals that are either 45 years of age or above. Women that are above or equal to 55 years of age, or those who meet the threshold for 2 or more risk factors. Immediately they have more than 2 risk factors or exactly 2 risk factors, we can consider them as moderate risk. And the age mark that particular aspect of the age. For men, when it is low risk, is below the age of 45, or when it is moderate risk, is equal to age of 45 or more. But when it comes to high risk, individuals with more or one or more signs of symptoms, or with non-cardiovascular pulmonary or metabolic disease, including diabetes mellitus. We've actually mentioned this in the previous slide. A comprehensive pre-exercise evaluation in the clinical setting generally must include medical history. When it comes to medical history, you go back to what they taught you in the aspect of clerking. You are supposed to know what is the history of that individual in terms of what brought him to the hospital. Why is he actually, why was he asked to go through, to come for exercises? So you need to know that history. Again, what is the past medical history? In this case, you want to know hospitalization and other risk factors that you may actually get through that. You need to have comprehensive information about the general, including family social history of that individual. You want to have everything that has to do with the history that may actually put the individual at a particular risk classification. Then physical examination, you want to know whether he has certain form of injury. Probably this individual, sometimes they tell you somebody have obesity or somebody is diabetic, and they ask the individual to come for exercise prescription under physiotherapist. But the same person, if you did not do physical examination, you quickly rush and give the individual a certain form of exercises to go and perform, and you realize you are not getting result. Probably it's because this individual actually have knee OA, which is a physical, during your physical examination, you would have noticed this, and therefore know the type of exercise you are going to prescribe for the individual. So you need thorough physical examination as well to be able to prescribe the type of exercise. Then you go to laboratory test for, let's say, for individual with let's say diabetes. You want to know what is the fasting blood sugar and many other laboratory tests that may actually help you in trying to make your prescription of exercise. Few terms in exercise screening and service orientation. Number one is PACU, Physical Activity Readiness Questionnaire. This is a very important tool, and it is expected that every physiotherapy clinic should have PACU in their clinic available as part of what should be included in the case file of many patients that will be requiring exercise. Unfortunately, many physiotherapists don't even know about the PACU. Many do not even know about the PACU, talk less of even knowing how to administer it or use it for screening. So, and the people that do not know anything about PACU are busy administering what? I mean, recommending and prescribing exercises. Sometimes you heard that a particular patient came to the hospital today and he went back home. The first day he came, he was okay. After you say you give them prescription for next time, and you have already given them some home program without necessarily knowing whether the patient actually has some underlying challenges. After giving them everything, to do certain exercise. They say he was doing the exercise you prescribed and he died at home. Do you know whether the one that prescribed a quick, what do you call it? Quick death, let's say, drop for him. The exercise you prescribe is what actually killed the patient. So all these are very important things. We're going to be looking at the PACU, how do we administer the PACU and all that. Informed consent, documented acknowledgement by client of the or patient of the risks and benefits of exercise participation. You must make them know what is the risks of participating in what? In exercise. What are the benefits of participating in exercise? A number of times, we only give patient prescription for a particular treatment. We do not tell them, these are the benefits, these are the risks, these are the challenges you are going to meet. As simple as administration of cryotherapy, where you are supposed to tell the patient, you are going to feel cold, you are going to have numbness, you are going to have this, you are going to have redness, you know, and all that. No, but we do not even tell them what they are going to go through. What are the things they are going to experience? So all these are details that patients must be aware of. And after you have educated them about what they are going to go through and the experiences they are going to encounter and the risk of getting involved in the exercise, then you now ask them, do you agree we should continue? And when they say yes, you must equally document it that patient consented to participate in this exercise. And that's all. You are covered legally. Unfortunately, because our state, our country does not have anything we continue to do whatever we want. Then we go to bioelectrical impedance analysis, a technique to assess body composition and health metrics. Unfortunately, we hardly do use these electronic gadgets to assess such things in our setting. So, so we just do whatever we want, but nevertheless, we can use body composition assessment, like the use of BMI. We can assess patient using BMI. We can use percent body fat. We can use waist to hip ratio. We can use waist circumference, and all these can be documented as part of our assessment for the patient and readiness of the patient to participate in an exercise program. Confidentiality, agreement, assurance of privacy regarding client information. You must assure the patient that your information and all these things you tell, I'm getting this information I'm getting from you are going to be confidential. Aside from me and the fact that I'm going to document it in your case file, nobody will be aware of the information you declare to me. Client-centric approach. I've mentioned about patient-centered approaches where patients are actually involved in prescription and determining the goal that the patient wants to achieve after your prescription of the exercise. Focus on tailoring services and interaction to individual client needs. What is the need of your patient? Make sure that your exercise prescription is tailored towards that. So this is the PACU, Physical Activity Readiness Questionnaire. So in this, I believe you can see it. You have, if the individual has a title, I'm the chief, I'm the Sarki, I'm the emir, I'm a doctor, I'm a pharmacist, I'm a nurse. If that is their title, recognize that title and put it there. Then the name of the patient, then the surname. Date of birth is very important. Why? Because that will help us in trying to know the age of the patient. The address, what is the address of the patient? The email address as well, if there is. It's a bit more complex in our setting to start demanding what is the email address of an individual. Of course, we can have the address. You may add to also have the daytime that you are doing the assessment, the evening, and you need to equally have the mobile contact of that individual. So in PACU, the assessment is basically yes and no. Responses are basically yes and no. The individual can be self-administered, and it can be therapist administered, where the therapist read out the question, listen, particularly the illiterate patient. You can read out the question and ask them, what do they think about what you read? Has your doctor ever said you have had trouble? The patient will answer whether yes or no, and you document that. Have you ever had pain in your chest? You write yes or no. Do you often feel faint or have spells of dizziness from time to time? You can actually ask the patient this. They will answer yes or no. Has a doctor said that your blood pressure is too high? Has a doctor said that you may have bone or joint problems, arthritis, that is aggravated by exercise? Have you been, or you yourself, sometimes you can modify this question. When you are actually walking, if, for example, you say, as the doctor say that you may have bone or joint problems, arthritis that is aggravated by exercise, and the patient say, my doctor did not tell me anything like that. But you can equally ask, do you have it? And that may serve as a representation for that same question. Have you been in hospital in the last 3 years? Are you currently taking any medication? Are you pre-stroke postnatal? Do you suffer from asthma or breathing difficulties? Do you suffer from diabetes or epilepsy? Do you suffer from an allergy? Is there a good reason not mentioned here why you should not take part in training session? This was prepared for a particular setting. They call it Southwest military fitness. You can actually replace that to suit your particular place. If you answer yes to any of the questions above, please provide a doctor's note before training. So when your client actually indicates yes to any of the questions above, now you refer the patient to a doctor until the doctor certify that the individual, despite the condition that he mentioned, can actually partake in exercise. Then you are free to ask the patient to to partake in the exercise. Otherwise, you have to wait for the recommendation or, recommendation or endorsement of the doctor before you continue to engage the patient in an exercise program. The concept and practice of, now we're going to into concept and practice of stretching, warm up, and cool down. Now, I would like to take 1 or 2 questions before we leave the aspect of screening and the introduction. If there are a few questions, can I have the questions before I proceed? Are there questions?
Yes, sir. There is question, sir.
Oh yeah, can we go ahead?
Yes, sir. In the application of this PACU, a situation whereby a patient is being presented to you and you realize that that very patient have speech impairment. How will you apply this PACU skills on that patient? Are you going to use maybe a family member? Example, like all these CP patients that at times, majority of them have this speech impairment. How can you apply these techniques on them, sir? Thank you.
Okay, first of all, PACU is not for pediatrics. PACU is for adults. That's the first thing. But then you can have an adult that actually have speech impairment. So often you can actually involve family members if they have history of the patient. You can actually do that. The other thing is that, we do not usually have a comprehensive health system in Nigeria. Ordinarily, all our hospitals are supposed to have people who have knowledge of sign language where the individual can still be communicated with, and whatever response the individual is giving, you can document that. So you can, at your own level, whatever way you feel that you can communicate with the patient by gestures to know whether the patient have one challenge or the other, and you feel that the patient is getting it, you can use that to be able to know whether to expose that patient to exercise or not. I hope that answers your question.
Yes, sir.
Yeah.
Yes, sir.
Any other question?
Yes, sir. Please, thank you very much for the presentation so far. I actually didn't grasp the way you were able to differentiate between minimal, moderate, and high risk, please. I remember you saying something for male that between 45 and below, and all that.
All right.
Female.
So when it comes to risk stratification, the first thing we need, let me explain what is risk stratification. The risk of an individual being exposed to exercise that it may result into something that may be challenging. The likelihood of developing exercise, certain complications on exposure to exercise. That is what we mean by risk classification in the first place. So now, when it comes to classification, we have low risk, we have moderate risk, and we have high risk. Now, for male, when an individual is below the age of 45, if he is a male, he has low risk of having complications following an exercise. And let's say aside from the age, which is below the age of 45, the individual said, I often have, when you look at the PACU, go back to the PACU, you will see he mentioned only, he said yes in only one of the questions that is there. You see, his being at risk of having challenge is only one risk. So that individual will be considered as having low risk. But for a female, even if she's above 45, we still consider her at low risk, provided she's not up to 55. So if a woman is still 53, she's still 54, plus only one, one risk factor. So that woman is also classified as low risk. But if a man is above 45, immediately is 45 and above, and he has additional risk factor, that individual is moving into moderate risk because his age is above 45. A woman can only enter into moderate risk plus one or two, let's say, risk factors. That is when she becomes moderate risk. But if she is still around 40, 50, 51, 52 to 54, we still consider her as being in the low risk. I hope that is clear. Then when it comes to high risk is when somebody is already presenting with a clear medical condition. He has a cardiac disease. He has a particular cardiovascular condition. He has a particular metabolic condition. It doesn't matter. The age of that individual is not important. I hope that is clear. The age is not important, provided he presents with these conditions, either a cardiac condition or metabolic disease condition. Age is not important. The condition is what we focus on for us to classify that individual as being under high risk. I hope that answers your question.
Yes, sir. But in these conditions, once somebody have this prevailing medical condition and it is under control, for instance, some people are hypertensive, they take their medication and it's in control.
Thank you very much.
Others do not.
You see, what I want you to understand, we are not saying that low risk, moderate risk, and high risk are not qualified for exercise. So I did not say that. So what I'm saying is that you should understand that by presenting with this condition, the exercise prescription and the monitoring you are going to give these patients will be different because of their level of risk.
Okay.
I hope it is clear. It is not that
Yes,
they are
sir.
saying that rule them out, don't give them exercise. Remember, we said diabetes is under high risk. Are we not exposing people with diabetes into exercise?
We are.
But what we are saying is that when we prescribe exercise to them, they deserve close attention compared to somebody who is at a low risk.
Okay.
Is it clear now?
Thank you so much.
Yeah. Any other question, if any?
Yes, sir. Our guest lecturer, sir.
Yes.
Please, sir. I want you to mention those metabolic conditions that you've mentioned, cardiopulmonary and metabolic condition, but I want you to tell us those metabolic condition, and I want you to dwell more on it. Then, as far as what you just explained, if I understood what you've said, that those that have already medical conditions, you are trying to say that they should have more thorough supervision in carrying out exercise. As a therapist, we need to carry out more thorough supervision in order to prevent them from having any other complication or damages that may arise due to maybe lack of supervision or lackadaisical attitude. If I'm very correct, sir.
That is very correct. But it's so simple. Now, what is metabolism? If you know what is metabolism, that's all you is. Diabetes is not a metabolic condition.
Sir, it is, sir.
So what other thing do you need?
Okay, maybe there are more to it, so that we will, because the purpose of us coming here, purpose of me coming here, rather,
you want elaborate. You want elaborate. Remember,
something more comprehensive, sir.
When we are going to talk about metabolic condition, we are going to stop this particular lecture and go into metabolic condition. If you want list of metabolic condition, I will give you list of metabolic condition, probably in the next session. But in particular, the lecture is about getting started with what? Exercise therapy, right? Are we together?
Yes, we are.
I'm with you, sir.
So if you want list of metabolic condition, we'll give you more list of metabolic condition. But we cannot start discussing metabolic condition because the main focus of this lecture is for you to have specific condition that you identify. Then we focus on exercise therapy itself. But if you want more metabolic condition, I can give you more metabolic condition. That's not a problem. Is that clear? Hello?
Yes, sir. Yes, sir. Yes, sir. I've
right.
muted myself. I have to unmute.
Right.
Thank you, sir.
All right. Any other question? If there is none, we are going to move to another thing completely. Can we proceed now?
Yes, sir, we can proceed.
I guess we can, right?
Yes, sir, we can, sir.
Okay. So we're moving into the concept and practice of stretching. Warming up and cooling down. You see, the thing is, when it comes to exercise, and I'm happy a great number of you are in the uniform men. One of the things, my son went for this NDA screening some times ago, and I was very happy with the fact that such kind of assessment is there in NDA, because it is very important to know. Okay, sorry, this is not. I think, yeah, I'm supposed to say what I'm saying now under screening, because a number of cases are there that people are exposed to exercises without screening, and some of them even develop myocardial infarction. Some of them fall down and died instantly because of cardiac arrest. So screening is so important that you don't joke with it. So please, at your workplaces, emphasize that aspect when it comes to exercises. Your activity as uniform men involve a lot of things that has to do with exercises and keeping fit. Aspect of screening, and one of that thing is that, you know, some of us like dodging issues. When they ask us to go and do one or two things, we feel that I want to lose my job. It's better you lose your job than to lose your life. So people should be aware of this. So let's talk about concept of the concept and practice of stretching, warming up, and cooling down. So the major focus of this particular session is for us to look at, to understand the physiological and psychological benefits of warm up and cool down. So we are going to be looking at that now. When they talk about warm up, they call it pulse raiser. Something that raises your pulse, prepare your body for what is coming. A number of times people get themselves start exercise. When it's jogging, you start running immediately. When it comes to this, you start it immediately without preparing the body that I'm going to introduce something to you. Such attitude of getting the body involved instantly in an exercise program is very, very dangerous. So when we say general warm-up, we say pulse raiser. The second aspect after warming up is actually stretching. People should understand that warm-up is different from stretching, and warm-up should come before stretching. Specific warm-up practice of skills involved, we're going to talk about that, psychological preparation, focusing, anxiety control, and all that are very important, and they are part of warm-up program. A number of times people are called upon to come and do exercise or partake in an exercise program. You realize that probably this is a lady that is actually, is a young lady who is, let's say, for example, she's at the age of 15, 17, 18, like the type of girls we have now. And you'll be thinking that this lady is 25, 30 because of her body size. I recall one joke. Somebody was telling me that a guy went out with his wife, and a friend saw him. And when they met in office the following day, he was like, Usman, were you at ShopRite yesterday? He said, yes. I saw you now with your mother. And I decided, I don't know whether you will not like it. That's why I decided not to talk to you. And he was saying, which part of ShopRite? He said, were you not the one picking this, picking that, picking this? And he described perfectly what Mr. Usman was picking. And immediately, Mr. Usman got home. He said, young lady, from today, you have to start going to the gym. And this lady was like, I'm enjoying my body like this. Don't force me to do exercise. He said, even me, I like your body like that. But I cannot allow people to be calling you old woman, that you are like my mother. Now, the thing is the lady prepared for exercise? I think clearly we can say no. So now, but then there is body shaming. There is an aspect of her husband that is now becoming disturbed because of the weight of his wife. We now have to balance what is the perception of the husband and the preparedness of the lady to be involved in an exercise program, which means definitely to prepare her psychologically is so key. What is actually the reason why she doesn't want to partake in exercise? Is it only because she likes her figure? Or there are some other things, underlying things that she's not telling us? All these we have to trying to find out and see how we can prepare her to partake in an exercise program. That is what psychological preparation is all about. Again, probably if I may add this, I recall when I was an intern some few years ago, let's say 26 or so years ago. I met this. I went to the orthopedic ward of University of Ilorin Teaching Hospital then, and a patient was actually referred for physiotherapy. And I had some other patient telling him, obituary. What does that mean? I say, what do you mean by obituary? Hey, you are dead, referring to physiotherapy. And the patient was already shedding tears that, with this pain, and they are now saying that I should go for physiotherapy. What is going to happen to me? These people are going to kill me. Now, a patient that already have this mental, emotional, that is in this particular emotional situation, don't you think he need actually psychological preparation before you engage that person into therapeutic exercise? So some of these things are often ignored. When a patient comes to us, we quickly go ahead, do this, do that. We did not bother to know, is the patient, prepared to partake in the exercise? And that's why you see patients already withdrawn. They are not part of it. They are completely moody. They are not paying attention to their activity. They are absconding and all that because their mind is never prepared for the activity you are exposing them to. So we need that aspect of psychological preparation to get our patient going. So, benefits of warm-up. So you have better oxygen delivery to muscles when an individual do what? Partake in, when the individual partake in what? In warm-up. How? Because what is the role of oxygen when it comes to activity of the muscle? It is the sole provider of energy, and therefore, which means if we expose patient to warm-up, we are making the what? We are making the muscles to be well prepared and more energetic to be able to partake in the exercise. And they will be able to endure the type of exercise we are exposing them to. Improved blood flow. When you have improved blood flow, you have minimal level of pain in the muscles. Often, we have what we call physiological pain in muscles. Whenever you press a bulk muscle, particularly in its belly, you feel certain level of pain. Now, when you are now exposing an individual to exercise immediately, that tension is still there because of the tone of the muscle. But by the time you now give an individual a warm-up, you will lubricate the muscle more, and the chances of reducing pain is actually improved. And you now have patients enjoying the exercise afterward. Increased speed of nerve conduction. When you do warm-up, the nerve conduction also becomes faster, and that is also very helpful to the person engaging in exercise. Reduction in likelihood of muscular injury. You've lubricated the muscles, you've increased the energy of the muscles through oxygen delivery, you've increased pliability of the muscles through blood flow, and the likelihood of having muscular injury will automatically decline. Increased heart rate. Definitely, you prepare the heart towards what? The exercise program that you are about to. So the heart rate heightened a little bit, physiologically heightened, and that is also very good for preparation towards an exercise program. What are the psychological benefits? Control anxiety. The anxiousness that the patient have, you actually are going to control anxiety of the patient. That is going to be very helpful, preparing the mind of the patient towards the exercise. Focus mind. The patient has attention completely focused in the activities you are about to prepare the patient. Practice skills. You have already introduced the patient to the activity, and therefore he already learned some level of what he's going to engage in. So he has improved his practice skill, and that will be very helpful towards the program of the exercise we are exposing the patient to. Now, let's go into stretching. I told you that immediately after warm-up, the next thing you go for is stretching. What are the important points to consider when stretching during a warm-up pose or pose raiser prior to stretching. Make stretches goal specific. If you want to do an activity in the lower extremity, why are you focusing hugely on stretching of the upper extremity and ignoring the lower extremity? So again, if the activity I want to do is actually an anaerobic exercise, so the type of stretching I should do should actually focus on the type of exercise I'm going to expose my patient to. So it must be the goal of that particular, what is the goal of the main exercise that the patient is going for? Your stretches should focus on that goal in preparing stretches for the patient. Then begin slowly. Start your what? Your stretches slowly. Don't start pulling anyhow. Go slowly, slowly until you now. Stretching actually means extending, pulling the muscles apart at lengthening it. And that is what we call stretching. Since you are trying to lengthen, you don't lengthen at what? Because before you know it, you may actually cause muscle tear. But go gradually until you are able to stretch the muscle properly. Stretches held for too long or not long enough could cause what? Injury. So you must not stretch for a longer period. And when it is also too short period, you may likely cause an injury. So it must be a moderate level of stretching. Never hold a stretch which causes pain. If the stretching is causing pain, do not hold it. Release it. We are not after making the patient what? To have increased pain. Long, in fact, usually we say you counter the direction of pain. What do we mean by countering the direction of pain? If, for example, when I'm stretching the elbow, trying to extend the elbow, the patient is actually feeling pain. So instead, I will now flex the elbow and now ask the patient to extend the elbow by himself actively while I resist it. My process of resisting it will actually open the joint. And at the end of the day, I have better stretches. And by the time I now come to stretch, I'm going to get the stretch I needed. But do not forcefully stretch a particular muscle when that muscle is in pain. Do not bounce when you are trying to what? When you are trying to stretch. Do not be hitting in a bouncing manner. That ballistic movement. Do not do that. Like jerky movement. Do not create that doing stretching. Just make it one stretching, a pull, and you sustain the stretch. But like I said, not too long, not too short. Balance and equalize stretches of the agonist and the antagonist. Focus on both agonist and antagonist. Do not focus essentially on what? On the agonist, ignoring the antagonist. And do not focus on the antagonist, ignoring the agonist. What do we mean by that? Remember, I just told you that assuming I want to stretch the elbow and I realize there is resistance, so much of resistance, instead of that, I can go into flexing the elbow and asking the patient to extend it while I resist that movement. At the end of the day, I'll be able to have a balanced movement where I have the stretching I want to gain is coming, and the resistance I'm putting towards the antagonist is helping me in my stretches. So stretching must be conducted after the warm-up. So stretching comes after warm-up. You don't do stretching before you go into warm-up. You start with warm-up. Remember, we told you the warm-up helps you to lubricate the muscles, help you to stimulate the nerve conductions and all that. So all those aspects, they've already prepared the body to go into what? The stretches you want to introduce. So it must come after warm-up. It must be specific to the activity. I already told you that stretching must be goal-oriented. Stretching improves flexibility. This is the advantage of it. It improves what? Flexibility, increases relaxation of muscles, and improve muscles' ability to withstand the forces involved in an exercise. Stretching can be either static, no movement, or dynamic with movement. So we can do a stretching that does not require what? Movement. And we can do a stretching that actually require movement. Most static stretches, they involve keeping the muscle in a form of stretch manner and applying resistance against the movement of that particular muscle, which helps you to build tension inside the muscle and allow the muscle to stretch on its own. There are 4 types of stretching you need to know. Let's look at them. Active stretching. Holding a stretch position by contraction of your own agonist, which means the patient would actually pull the hand in a stretch position by contracting the muscle, keeping it in a stretch position. For example, stretch out your elbow. You now see, and you keep it in that position for a long time. That is an active stretching. It increases active flexibility, strengthens agonists. It is usually very difficult to hold over 10 seconds. So it does not last long when it comes to active stretching. The next one is passive stretching, a stretch position being held by something or other than the agonist muscles. So where you can use an item to help to do that. You can equally use, the therapist can equally be the one that is providing the stretches. So those ones, we call it passive stretching. It is good for cooling down and reducing post-exercise muscle soreness. It helps a lot in that. Then we have what we call static stretching. Isometrically contract stretch muscles are much more effective than the previous two for strength and flexibility. So when you are looking for strength and flexibility, you use more of static stretching, and it is usually very, very effective in that. If you know isometric quadricep movement, quadricep exercise, it is a good form of passive stretching of the lower extremity. Then we have, for example, a partner can hold high while you try to push down or push the ball of calf stretch. For example, the hand, an individual do like say straight leg raising. He did straight leg raising, SLR, and somebody now resists the individual from bringing the leg down. Or you can actually move close to the wall, place your leg there with your buttock almost touching the wall, and now press the heel of your leg on the wall. You feel total stretching of your calf muscle. So this is very, very helpful as well. PNF stretching, ballistic stretching, using movement to bounce in and out of stretch position can cause injury. We do not use ballistic or PNF stretching, that's proprioceptive neuromuscular facilitation type of stretching for preparation for exercise. We don't use it. So often we can do normal stretching. PNF should be reserved for treatment purposes. Those type of ballistic stretching or PNF stretching, they are considered dangerous. They do not allow muscles to adjust to stretch position and can cause muscles to tighten due to stretch reflex, particularly ballistic hamstring tear. For patients that are having neurological condition, it may even increase the level of spasticity in such group of patients. So try to avoid those kinds of stretches. What are the benefits of improved flexibility? Stretching, majorly what it does is to increase flexibility. So what are the benefits? The range of movement around a joint, increased range of movement around a joint. Decreased chance of injury. Ability to hold aesthetically pleasing gymnastic position. You stay in that gymnastic position for a long time, aesthetically, without having much problem. greater reach, help you to be able to reach further, particularly in cases of basketball, tennis, and so on. They do a lot of stretching. It helps those type of stuff. Can apply more power or longer levers in athletic activities. People who do stretching, they have better levers and in sporting activities. So what are the benefits of cool down? So after, interestingly, most of the activities we use during warm-up, they are the activities we actually do again during cool down. We repeat those activities during cool down. And these are the benefits of doing that. It aids removal of waste products, lactic acid particularly, which may generate too much pain in the joint. It reduces potential for delayed onset. It reduces the potential for DOMS, delayed onset muscle soreness. Reduces chances of dizziness or fainting caused by pooling of what? Blood at extremities, which is also very possible, and that is the cause of sometimes we see a patient fainting during an exercise program. Reduced level of adrenaline in blood, reducing anxiety after the exercise. Allowed heart rate to gradually return to normal rate. Should include 5 to 10 minutes walk/jog and 5 to 10 minutes static stretching. So these are the things that are required: 5 to 10 minutes of walk or jogging, or 5 to 10 minutes static stretching. They can be used for cool down. One thing that I would like to add is that research actually indicates that for sporting event, warm-up should not exceed more than 5 minutes. Warm-up should not exceed more than 5 minutes. When it exceeds more than 5 minutes, the performance of that athlete will be poor. In most cases, the performance of the athlete will be poor. Let me give you an example. For people who like watching football, I believe you've seen where somebody will be asked to start jogging because he wants to substitute a particular player. And he has started doing that warm-up. He was warming up outside, and it has taken long duration for him to be doing it. And the coach has not concluded on bringing out the player that he wants the other guy to replace. Oftentimes, the coach will still call that individual, go and sit down, and the person will go and sit down. They usually, they are not doing it, what do you call it, blindly. That thing is not done blindly. They will say, go and sit down, and the individual will go and sit down. But the coach still has it in mind that this individual will come to the field. When he asks him to get up again, he will ask him to do another warm-up. He's not going to ask him to just enter the field again. Except if the time that he sat down, it's not long before he concluded on substituting the other guy. If the time is long, let's say up to 15 to 20 minutes, he will ask the individual to do another warm-up before the guy gets into the field. But most sporting events, they do not allow the athlete to do warm-up beyond 5 minutes, because doing warm-up beyond 5 minutes, research has indicated that it is even detrimental instead of helping to improve the performance of the athlete. So we are done with stretching and warm-up. Do I have some few questions? We want to go into another aspect. If there are questions, I'll attend to the question before we go into another aspect. Are there questions? Am I audible?
Yes, you're audible, sir. No question. You
Yes,
can
sir,
proceed,
yeah.
sir.
You can proceed, sir.
All right. So we're going into range of motion exercise. Like I said, some of the things we are talking about, they are not new to a number of us. We know them. We are just adding to our knowledge. The second session is what we'll be talking about, things that are significantly new, but these ones are things that you probably did at a lower level of your learning, but it's majorly like a reminder, but I hope we can pick one or two things that we add to our knowledge. Now we're going to talk about range of motion exercises. Range of motion exercises are those which help to prevent contractures, joint stiffness, by moving all of the patient joints through their complete range. So the patient is moved through a complete range so that the range of motion that is limited by one condition or the other is improved through this exercise protocol. So what are the main reasons for range of motion exercise? To prevent and restore normal movement of joint, to prevent contractures, to stimulate circulation, to improve and maintain muscle strength, and to maintain or restore coordination, I mean. These are the things that the reasons for doing range of motion exercise. What are the types of range of motion exercise? We have active ROM exercises that client is able to perform independently by himself. So we call it active ROM. Then we have passive ROM, exercises performed for the client by someone or by a gadget. Then we have active assisted ROM, performed by a client with some assistance. Client can move a limb partially through its ROM, but needs help completing the ROM. Now, this is not comprehensive enough. There could be a circumstance where client cannot initiate a movement, but when you assist the client in initiating the movement, the client can complete the movement. Then we have auto-assisted ROM. Auto-assisted ROM is a situation where the patient is the ones supporting or doing it by himself. In this case, you have one limb that has limitation, and the patient is using the other limb to help the limb with a limitation. So we call it auto-assisted type of ROM. So what are the general guidelines for ROM? So passive ROM exercises should be done only on patients who are unable to do it on their own. If a patient cannot do it on his own, we actually do it for the patient. So why do we do passive ROM? And another question is, can passive ROM actually increase the strength of a muscle? Now, the answer to that is that we do passive ROM essentially for maintenance reason. If the range of motion of the joint is full, let's say the range of motion, there is no stiffness in the joint, and the patient can take the joint can be taken to the full range. But the only problem is that the patient cannot do it by himself. In such a case, we do passive ROM to maintain the muscle tone and to maintain the joint integrity. These are the major reasons for doing passive ROM. But passive ROM cannot and does not in any way increase muscle strength. Passive ROM exercises should be done to patients with slight resistance as well. When they have minor resistance too, we could actually help them here. Never do ROM exercises beyond the capacity of the individual that is to the point of discomfort. If there is this erroneous belief that they say no pain, no gain. This is a useless belief, and it is not for physiotherapists. We do not initiate pain to punish people and start saying that because we want to gain something. No, you are supposed to remove pain. You are not supposed to induce pain. So if you are taking an ROM beyond the capacity of the patient, that the patient is suffering from discomfort or pain, you are not doing the right thing. So we take it to a range of the minimal level of pain that the patient can bear. And that's all. Move body parts smoothly, slowly, and rhythmically. This is how to move it. Go slowly, go smoothly, and go what? Rhythmically. This is what we are expecting somebody to do during passive ROM. Expect heart rate and respiratory rate to increase during exercise, which should return to resting level within 3 minutes. If not, exercise is strenuous for the patient. So almost all type of therapeutic exercises that we expose the patient to, the changes with cardiovascular or cardiorespiratory changes that we see, all of them must be restored to normalcy after 3 minutes. If the patient cannot return to all those parameters do not return to normalcy after 3 minutes, then the exercise you're exposing the patient to is well beyond the capacity of the patient. If muscle spasticity occurs during movement, skip the movement temporarily, but continue to apply slow, gentle pressure on the part until the muscle relaxes, and then proceed with the ROM exercises. Now, when you are trying to actually mobilize a particular joint, your focus is on the joint. But then you now realize that at the cost of trying to mobilize the joint, you have muscular spasticity or muscle spasticity. What you are supposed to do is be gentle on the muscles, because the more pressure you add to the muscle, the more likely for you to, particularly when it is a neurological condition, you are likely going to heighten the level of spasticity. So, but when you are gentle on the muscle will relax gradually. So immediately you are able to achieve the relaxation of the muscle, you can now focus on what? The range of motion exercises. Because your major focus is, your major intent is for you to do range of motion exercises. But now you met a resistance because of the what? Spasticity. So work on the spasticity first before you now go back to the range of motion exercises. Okay, assessment. So when you want to start range of motion exercise, one of the key things that you should know is that you must conduct assessment. At every stage of practice, physiotherapists must know that they are not street mobilizers that are not trained. They are trained, and their training is telling them that you don't do anything blindly. You don't do anything blindly. Assessment of patient at each and every level is very important before administering any form of therapy. So, and that is why assess the patient's level of comfort before exercises. How comfortable is the patient before you administer the exercise? If the patient is not in good shape, why administer exercises? You are going to put the patient under more tension. Review the patient's chart for physical assessment findings. Get to the case file of the patient. What are the physical assessment findings that they have? Look at it before you now go ahead. If there is none, conduct your own and you proceed. Obtain data on the patient baseline joint joint function. If there is such data inside the case file, look at it. If it is not there, do examine it, and before you start your own exercises. What are the special points here? Move each joint through its full range and follow regular pattern of movement. What we mean by regular pattern of movement is that if I'm going flexion extension, it should be flexion extension. When I'm switching to go back into supination pronation, I should switch smoothly into supination pronation. Usually movements are in pairs. You have this and this. For example, adduction, abduction, flexion, extension, pronation, supination, dorsiflexion, plantar flexion. So you see, so this pattern or regular pattern should be maintained. When you do a switch, go smoothly. Do not always tell yourself that, let me do extension, flexion, extension, pronation. No, go in regular pattern. This will make a better sense and give you a better result. Provide passive ROM exercises 2 times a day. Sorry, that's a wrong thing. 2 times a day. Provide passive ROM 2 times a day. Minimally, for patients who needed passive ROM, give them minimum of twice in a day. Now, this takes us back to my statement of home program. So now, you decided, you saw this patient in the morning, and the patient, it is time for the patient to go home. It's an outpatient case. So how do you do your second one? You quickly join Okada. Go home, oh, I'm coming. Because according to practice guide, I'm supposed to give you minimum of 2 ROM in a day. Go home. I will come with my car or quickly join the next tricycle to come to your house to deliver my second ROM. And now I go back to the hospital. Who is paying you for all that journey? How is it feasible for you to continue with this kind? And how many patients will you be able to see that actually require second ROM of the day? If you have 20 patients, now start going to, you have done the first ROM in the morning, in the evening, and all of them are living in different parts of the town. For this time, you now say, okay, I'm done with patient 1. Let me go to number 2 until you go to the 20th patient. Because you are Mr. Serious, deliver a real kind physiotherapist, and extremely, I think the government is sponsoring all your journey to go from one house to the other to deliver second ROM. The thing is, this is not feasible, and what only makes sense for you to teach the family how to conduct the ROM and for them to do the second ROM at home. And if we say minimum of 2 times in a day, so who is going, since you are seeing this patient every, let's say twice in a week or 3 times in a week, who is going to deliver the remaining what do you call it, ROM, for the remaining days that the patient is not coming? And how do you expect yourself to see results since there is no continuity? So it is important for us to have a home program to be able to sustain and improve the level of performance of our patient. Support measure should be used to prevent muscle strain, as injury may occur during ROM exercises. So everything that it takes to reduce the chances of muscle strain should equally be done. So now let's look at some of these key actions. Explain to the patient the purpose of performing the exercise. So what is the reason why we need to do that? We actually need to do that because that will ensure cooperation of the patient. Remove rings or other restrictive jewelry if present. In case of hand swelling, this may impede circulation. So when these jewelries and whatever are there, it will surely impede circulation if they are not removed. Remove all tight fittings, clothes, and provide a hospital gown so that your activity will be smoother. Ensure comfort of the patient. So when you remove such, it ensures comfort of the patient. And of course, the therapy application will be a lot easier for you as a therapy. Provide privacy and wash hands. When you do that, it reduces patient anxiety and risk of transfer of microorganisms when you wash hands. This is one of the areas where you now have nosocomial infections. People don't take care of themselves. Immediately is done with this patient. The same hand he finish seeing this patient, he goes and touch another patient with it. Straight. Expose only the area that is being exercised. Reduces embarrassment of the patient. Somebody that is supposed to see the upper back of a woman, and the man is dropping and removing everything at the lower back and everything to expose them. Why won't she be embarrassed? Or it's a woman that is trying to treat a man, and somebody who has shoulder pain, and because he feels that this guy is chesty, remove the whole of your shirt, remove everything and all that. Somebody has calf affectation of the calf, and you now say put on short. and so that I'll be able to massage you to the level of the hip. Is there any need for that? If there is no need for a patient to overexpose himself, please ensure you don't allow such to happen. Position bed to an appropriate height so that you will not be, the comfort of the therapist will also be taken into consideration. Ensure proper mechanics. So doing that, ensure proper mechanics. Start proceeding passive element. Sorry, let me, I can't see this clearly. Start, initiate the ROM from the head. That's from the proximal to the distal aspect. But this aspect actually depends on what type of condition the patient is bringing. In a case of patients that are subconscious or probably bedridden, you can actually proceed from the head downward. So let's start neck. Move head through flexion, extension, lateral flexion, rotation, and hyperextension of the neck. Movement of head is contraindicated in spinal surgery, spinal trauma, and other central nervous system trauma, and for patients having central nervous, venous line. So this is only the contraindication. But ordinarily for patients who do not have issues with affectation of the spinal cord, you can, if it is the neck you want to work on, you move flexion, extension, lateral extension, rotation, and all that, hyperextension of the neck and all that, you do all that. So again, flexion, bring chin to rest on chest. Extension, return head to erect position. Hyperextension, bend head back as far as possible. Lateral flexion, tilt head as far as possible towards each shoulder. Rotation, turn head as far as possible in circular movement. So these movements are very, very essential when it comes to movement around the neck region. So these are some of the examples you will see. This is the neutral position. This is the extension. When you have extension, this is where you have flexion. And the extension, you can see as if we have almost nearly a hyperextension there. Right lateral flexion is also clear there. We have left lateral flexion, right rotation, and left rotation. These are movements around the neck, and I think they are self-explanatory. Then we come to the shoulder. Flexion, extension, hyperextension, adduction, abduction, and circumduction, external rotation and internal rotation. Shoulder should be supported proximally and distally at the course of movement. So when somebody is going to do shoulder movement around the shoulder, we say you support it proximally and distally. Often you are expected to put one of your hand at the level of the, just above, around the deltoid muscle, just above the shoulder. Then you give a little support around the arm, just below the elbow joint. So you now be able to take the movement. You remember this is basically ROM movement. So since you are the one doing it for the patient, it is easy for you to do all this. But when it is active movement that you are looking for in ROM, all these support, either distally or proximally, are not very essential. So what do we do in flexion? Raise arm from side position forward to position above head. So that's how we do it. We raise the arm from side position, a little bit side position, then forward to position above the head. You take it from anterior portion and lift it above the head. Then when it comes to extension, return arm position at the side again of the body. So when you bring it down to the side of the body, you've actually finished the level of extension. Sometimes you can equally take it a little bit backward, that is hyperextension. Move arm behind body, keeping elbow straight. That is an hyperextension of the shoulder. Then we have adduction, lower arm side again, and cross and across body as far as possible. You bring it inward. Adduction, move arms away from the body as much as possible. These are simple things that I believe they are self-explanatory, and I believe you can understand all this. So this is a typical example of such things. This is a flexion, we've seen it. This is where we have hyperextension. Extension is those one with dots, that is extension. Then the one when you see the arm without the dot, that is where it is what? Hyperextension. It's going up beyond the part of the body. Then you now have the adduction. You can see the position. When you move it away from your body, that is a position of, when you move it away from your body, you are going into abduction up to the level that you are able to raise it here and up to this place. They are all forms of abduction. Then when you move it across your body, immediately, it is now a process of adduction. Then we have outward rotation, which is also indicated there. Often this is performed when you have limitation in the range of movement around the elbow joint. It is very, very effective in increasing range of motion around the shoulder, particularly outward and inward rotation of the shoulder. Then we have the elbow. Here, the movements that are allowable are the flexion, extension, pronation, and supination. Support elbow joint both proximally and distally when you are trying to do this movement. And if like we say, the extension, bend elbow, so that lower arm moves towards its shoulder. It moves towards the shoulder joint, or let's say towards the arm, or what they call antebrachium. And hand is in the level with the shoulder. Extension, bring elbow straight by lowering hand. You do not have hyperextension of the elbow, except if it is a pathology. Pronation, turn lower arm so that palm is down. The palm should look downward. That is when you have pronation. And of course, when it is looking upward, that is when you have supination. This is typically the flexion and extension of the elbow. And these are the pronation and supination of the elbow as well. Then we have the wrist, the movement that are possible around this. These are the key actions: flexion, extension, hyperextension, and what do you call it? Lateral flexion, radial and ulnar. Then we have position, wrist in functional position. So usually the wrist should be positioned in a functional position. Then we have, what do we have? Flexion, move palm toward inner aspect of the forearm. That gives you flexion. Extension is there. Hyperextension, bring as far as possible. Back, that is 90 degrees centigrade, well above that. But all those are termed as hyperextension, and particularly when it is not pathological. Radial deviation, bend wrist laterally towards fifth finger. Ulnar deviation is also explained there. These are a typical example of that. We've seen a hyperextension of the elbow in this case. In this case, this is extension when it is in the neutral position. When it is straight, then we have what do we call it? We have the flexion. Then we have ulnar flexion and radial flexion as well. So what happened in the case of the fingers? Move fingers through the flexion, extension, hyperextension, abduction, adduction, opposition of the thumb, and circumduction of the thumb. These are all possible in the wrist, in the finger areas. Flexion, move across palmar surface. When you move your fingers, they're particularly in the phalangeal joint, let them move toward the palmar surface. It is a form of what? Flexion of the fingers. Extension, move straight away. So move them away from that position. It's actually give you the movement you are looking for. Extension, move straight away. Adduction, extend laterally, and so on. Now, when, of course, opposition is also there, it helps in fine motor skills. Much of the time, I use opposition a lot, particularly when I'm trying to improve fine motor skills in my patient. Opposition is hugely where you make the fingers to oppose the thumb, and this is very, very helpful in the rehabilitation of the hand. So this is adduction, is clearly there. That is when you open. Opposition to little flexion. This is it. Then extension is also provided there. Hip. Move hip through flexion, extension, abduction, adduction, internal rotation and external rotation, and circumduction with support above and below joints. This, you have flexion, move left forward and up, and that the extension is there, the adduction and whatever. And I believe if you have any question to this, you can actually ask. I think this is self-explanatory as well. So this is typically what we are saying. You have flexion. Extension is when you bring it down. Flexion is when you lift it up. Then you have abduction, abduction, moving away from the body. Abduction, adduction, bringing them towards the body. Then we have onward rotation, which is rotating the entire limb inward or outward by moving it in those directions. You have the knee. The main movement allowable in the knee are the knee flexion and extension. Then we also have the ankle, plantar flexion, dorsiflexion, circumduction, eversion and inversion of foot are all possible around the ankle. So let's look at the knee, the flexion. Bring heel back towards back of the thigh. That gives you what? Flexion of the knee, which is often executed by the hamstrings. In neurological condition, this is nearly impossible. The hamstrings are totally weak, and it's only when you have hemiparetic cases that you see movement around. I mean, the hamstring being able to flex the knee joint. Then we have dorsiflexion for the ankle foot. Move foot so that toes are pointer upward. Plantar flexion, move foot so that toes are pointed downward. Move ankle in circle. Inversion, turn sole of foot medially, and eversion is to turn it laterally. So these are movements that are now allowable around the ankle and foot. And this is a typical example of that. Toes. Movement that is possible is flexion, extension, abduction, and adduction, just like we have in the wrist. The only thing is just that in the wrist we have hyperextension and all that. So what do we have? Flexion, curl foot, extension straight to toes, adduction, bring toes together, and abduction is like fanning the toes, which is not documented there. Of course, we have wash hand to prevent cross-infection. Record procedure serve as legal in the document. Position the patient in a comfortable position to enhance comfort. Now, one of the major problems we have when it comes to practice in physiotherapy is documentation. What I mean here is that people do not usually prescribe and say that this is exactly what I did to my patient. You will see plan of treatment and they will just write down series, but the details of how this was done is usually missing, particularly what is the intensity, what is the amount of PM that the patient should have, at what time was this recorded, and all that is missing in our case files. And in case we have medical legal cases, we may likely have problem. Record the date, time, and duration of the exercise done. Specify the response of the patient. Specify whether the patient had any limitation in performing the exercise. Whether the patient had any limitation in performing the exercise. So all this you need to document in the case file of the patient. Evaluation. Evaluate the patient's response to procedure. How is the patient faring when you expose him to that exercise protocol? Monitor for any adverse effects, such as giddiness and low blood pressure that may arise due to exercise performance. So all these are very important and you focus on them as well. Now, typical example of this is I'm actually seeing a patient. Let's say the first one is 07 instead of 17. It's 07 05 2025. Okay, okay. At 17/05 2025 8:30. What that implies is that the patient, this is the time I see the patient. I'm able to see him on 17th.
That was yesterday.
Yes. So so then range of motion exercises were told and demonstrated to the patient. You are documenting what you did. Patient demonstrated well, instructed him or her to perform 3 times. All these, this is what you actually document about what you ask the patient to do. You should write it comprehensively. Do not just say ROM exercise, PNF. Not just write, specify what you did to the patient. It's also very, very important. If the patient overdo what you ask him to do and there is something negative that happened, you are not going to be charged. But assuming, or probably the patient has been doing it inadequately and the result is not coming out. And one day you now say, and people are looking at your practice as if you don't know what you're doing, that the patient has not been improving. By the time the patient is reviewed and it was discovered that the patient has not been doing the right thing, who's going to blame you? So these are key things that are very, very important. So we're done with ROM exercises. If there are questions, let me take the question before we go into flexibility exercises. Any question for ROM exercises?
Yes, sir. Good morning, Prof.
Good
Thank you. I wanted to find out, what if in the case of contractures, how usually the normal practice is to sustain the stretch, is to use sometimes a kind of splint as much as the patient can tolerate, sometimes night splints or sometimes for a few hours. But you said we should not stretch, you know, to cause pain, but already the patient is in pain. And this was actually first due to a neurological disorder, that's stroke. And then again, before the client came in, he fell down again. And because of pain, he left the knee flexed. So at this point, what kind of stretch are we going to do? Because now you said we should not stretch to make the patient feel pain? How do we go about it? Already the patient is geriatric, the muscles are weak, there is contracture and there is pain. How do we handle this situation, sir?
You see, you contradict yourself a little bit. Sorry to say that. You say as much as the patient can bear. You say that when you're asking this question. So in a way, you answered your question. We're not saying there should be no pain at all. We said to a level that is bearable to the patient. It's not total elimination of the pain. But you must know the therapist will be aware that you are not supposed to deliberately instill pain and start telling yourself that the more pain, the more gain. Is erroneous. So you look at what level of pain is allowable that the patient can tolerate without causing more injury. Remember, what is pain in the first place? It's basically defined by the patient, not by you. It's what the patient expresses as pain that is called pain, not what you assume, because it's not your body. So if the patient say, I can't bear it, and that is it, he can't bear it, you may be looking at it, I only stretch it a little. This patient is not cooperating. No. You stop within the range that the patient can bear before you move forward. I don't know whether this is clear.
A little clear, sir.
Okay.
Because before the patient is touched,
and again, remember I said we have complementary therapy. You know, this is exercise therapy, right? The program is for exercise therapy. But it is not in every case of condition that when we now assess the patient, the first thing we do is the exercise. No. We may need to introduce some other complementary therapy. For example, cryotherapy, for example, all forms of electrotherapy gadgets to reduce the level of pain before we now bring the patient, before we now introduce exercise. So whatever will reduce the level of pain before we bring in therapeutic exercise, we are supposed to do it.
Thank you, sir.
Yes. Is it clear now?
Yes, please. Thank you, sir.
All right. Any other question?
Yes, sir. Thank you very much, sir. In addition to what the last person that asked question asked, you know, what you're trying to say that we have to consider the pain threshold of individual patients.
Definitely.
And we discover that most times when you keep limiting your activities to the level of pain they will tell you they can tolerate, it delays the outcome. And some people also have the fear avoidance, you know, to do certain things because they have a limited pain. So how do you just take all this into cognizance so you'll be able to have a positive outcome? Because I know you make it of what you call biopsychosocial model of management of your patient. But in most cases, we still have challenges because some of these patients, they have reservation, they have aversion. And even though that what you feel you're doing shouldn't cause more pain, but because they already have some fear in them that they may be their pain may be elicited, they complain. So I don't know. That is why I find it problematic as a therapist.
You see, what we are saying is that when it comes to patient management, it has to be holistic. Holistic in what sense? You are not looking at the physical presentation only. You have to carry along with it the emotional situation of the patient. There are times that patient comes to our clinic and we decide not to even touch the patient. All we do is to just have interaction with the patient. And that interaction alone, we allow the patient to go and without touching the patient. And the patient will return. And sometimes what we do when the patient is now going home, we now say, can you try ABC? I want to see what you can achieve. So, and oftentimes when you are going to give a patient something, you know, biofeedback is very important in the sense that the patient has to have confidence that I'm able to achieve it. Give patients an activity that the patient can perform, and the result may not be difficult to see. Now, when the patient is motivated by his own activity and is seeing results, attention is focused on the therapy more, and whatever you are trying to introduce, there is more confidence in the outcome of the therapy. So, and patients are never the same, agreed. They are usually a lot different. So you have to, with practice, you get to understand more handling of a patient, including their emotional status. But you cannot focus on the physical challenge of the patient alone. You definitely may not get results, because let me give you this example. Here in the North, you know, the largest percentage are Muslims. We had this patient. She's an elderly woman who has not been cooperating during therapy. So we now decided that now, and every time she comes, she was only telling us that she wants to go home. But one of the things we noticed is that she likes to look good, and when she's talking, she wants to impress. You see, how would you start noticing this? You need to pay attention to your patient, and everything about them matters to you in your therapy. So when we realized this, one of the days she came, we decided to do group therapy, and we make it a competitive type, and active and competitive. We were introducing things that literally all the patient will be able to do, except a little of them. So they continue with active ROM exercises, and we'll say, who is the first to achieve this? Let's go. Who is going to do this? Let's go. Do it together. Clap for yourself. Let's move on. And by the time we are done with the therapy for that day, the following week, when this patient returned, the family members say to us, the daughter called me aside and said, sir, I wouldn't know whether you will continue with what you did the other day. When we went home, the last time we saw Mama being happy, you know, here people go for Hajj. It's just like in the South, you have people going to Jerusalem. So they say the last time we saw this kind of happiness in her was when she came back from Hajj, because of the therapy you did. You know what was happening? Today, she was the one saying that we should go to the hospital. Let's quickly go. What are you guys? You guys are wasting time. You know, I was the best that day. I want to be the best today. So you work on the psyche of your patient. It helps a lot to prepare them for whatever therapy you are going to introduce. It's not a one-way route. You try this, it doesn't work. You try another one until you are able to get it right. You may not necessarily get it right at once, but the more you practice, the more you start getting it right. I hope this takes care of that. Hello? Any other question?
Yeah, I can hear you.
Is it clear?
Hello, good afternoon. If I
Good
may
afternoon.
hand a little. This is Aware from Lagos. Sometimes we take a multidisciplinary approach. There could be the role of analgesic temporarily. While the analgesic is going on, whether topical or ingestible, we still try to achieve our ROM, hoping that with the gain during why the analgesic is still active will be sustained so that the patient will not continue on the analgesic.
Yeah, that's a good one. But sometimes that should be sparingly done. It should not be something that is continuous for two reasons. Number one, you are afraid of addiction. That's number one. Number two, you are also afraid of injury. Why did I say injury? Physiotherapists have another conception about the use of analgesics. I'm going to give you an example with spinal cord injury. Okay. One of the things that we know about spinal cord injury is that there is loss of sensation. If you have a child and you ask the child, you put the hand of a child in, or even we don't even need to give an example with a child. If you mistakenly put your hand in a fire, would you leave it there? Definitely you are going to remove it. Why are you taking it away? Because of pain. So what is the use of pain? Pain is actually very, very important, which means pain is actually something very positive that is trying to protect you from further damage. That is the use of pain. Pain reduces further damage. That is the most important use of pain. So pain is not 100% a negative thing. It's actually it's actually an experience that helps you to run away from further damage. So when patients are placed on analgesics, one of the things we notice, particularly in musculoskeletal conditions, is that they take risk of taking certain movement that ordinarily they wouldn't have taken those movement when the pain, when they are not an analgesic. Now, if you take wrong movement because you are not feeling pain, you may likely cause further damage, which after the effect of the analgesic has vitiated, you are likely going to have more pain than it were at the beginning. So therefore, when recommending analgesics, we should recommend with caution and very specific for a specific reason and for a specific duration. Most of the cases you have about back pain and let's say musculoskeletal condition that are terrible, you realize that most of the patients have been long on analgesics. If analgesic is actually a positive thing, then it should actually be taking care of the condition. Analgesics are not curative. They are only working on the symptoms. So therefore, they are not working on the primary cause of the injury. I hope this explanation is clear.
Yes, thank you, sir.
Yeah. So can we go into flexibility training now?
Yes, sir.
Flexibility training, the ability to move muscles and joints through their full ranges of motion. That's what we mean by flexibility. To move muscles and joints through their full ranges of motion. And they can actually be performed, is more or less like ROM exercises, but they can be done actively as well, and they can equally be done passively. But essentially, when it comes to flexibility training, they are often encouraged to be completely active activities. They improve efficiency of movement and technique. This helps to save energy a lot. A person that is more flexible does not expend more energy when it comes to exercises compared to those who have problem with stiffness. They expend more energy. They pass through a lot of exertion more than people who have better flexibility. It increases other physical fitness component, in speed and agility of that individual is better for those who have better flexibility than those who have minimal level of flexibility. Examples of flexibility activities: gymnastics, held bridge position, the use of gym ball, and so many other things are helpful. Sprint stretching, legs muscles, yoga positions are all used for flexibility. So what are the two types of flexibility? We have static, we have stretching. Static relates to the range of movement only. It focuses on the range of movement only. The stretches, the process of elongating the tissue is what we call stretch form of flexibility. So you elongate the muscles, the tendons, the ligaments, and all that. When you give them a big of a stretch, it's a form, it aids in flexibility. So example of stretch activities for each type of flexibility: stretch to the furthest point and hold can help. It is the safest method, simple to carry out, requires little energy. It allows time for the muscle fibers to relax, e.g. holding a split position. You can equally use it TheraBand. You can use the gym's spring. All these are very useful when it comes to stretching. And of course, we've talked about isometric form of contraction. When it is done along with a form of resistance, it also helps in stretching and aids flexibility. Now, ballistic, which is bouncing, rebounding, and rhythmic motion. Momentum takes the moving limb or part of the body to its limit in order to increase the range of movement, e.g. swinging, flinging, and bobbing. They also help in flexibility. However, when it comes to ballistic form of or bouncing or rebounding, we use these essentially when we do not have injury cases. When we do not have injury cases, we use it in recreational form of flexibility. In recreational form of flexibility, it's very useful in that regard. And again, it's also used in sporting and among athletes. We also use it in athletes. Dynamic, this refers to the ability to use a full range of movement in the performance of a physical activity at normal speed of the action. It is performed under control and does not end with jerky movement. When you, particularly, you remember I mentioned about the issue of using TheraBand. You pull, you stretch fully, and you return, you come back. You take it out and you bring it in. So this form of movement that is in form of isotonic movement with full range of stretches are form of dynamic form of flexibility. The risk of injury is greater when it comes to ballistic as well as dynamic. They do not give time for the tissue to adapt and can increase muscle tension. And that is why they are more recommended for persons that are normal. I think I'll get the video. I wanted to play you a video, but I dropped the video somewhere. Okay. If I access the video, I'll play it when we come back in the second session. So warm up, cross country, arm swings, all these are part of what you use in flexibility. Active flexibility can, pardon? Okay. Active flexibility can be static or dynamic. It refers to the range of movement an individual can carry out without assistance. This is what we call active. Passive, the individual makes no contribution to the motion and an external force is applied. A partner assists or the person pulls himself or herself into the extended position to aid flexibility. Sometimes the passive one, I believe some of you manage spinal cord injury, where we ask patient to hold into a bar to get into sitting position. Those are form of flexibility activities. So this is the last, the end of the first session. We'll be coming back in the second session. If you have some few questions about flexibility, we can talk about it before we close this session. Any question for this session?
No, ma'am.
Any questions?
No.
About flexibility?
All points covered for now.
All right. Thank you very much for the patience for this session. I hope we return by 2:30. We start by 2:30 for the second session. And we proceed up to around, I think we close by 4 or 5 exactly 5 in the second session. Okay, see you then. Thank you very much.
Thank you.
Thank you, ma'am.
Thank you, ma.
Thank you very much. Sir.
Thank you very much. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you, sir.
Appreciate
Very
it.
much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Wow, what a long lecture. Very interesting. Wow.
Please, those that have not renamed their device name to their own name should do that before the next session, please.
What are we gonna do about our other mission? Get in shape for the beach? Done and done. No, I mean, tell you, we're fake friends. I mean, everyone knew we were speaking. We were hurrying to fake friends. But we turned out okay. I love you both the same. Not okay. Tell Chloe to leave on mission. Say her assignment is to go undercover at school as you find out what it's like to talk to real friends you don't want to students. Over.
Hello, sir. I'm surprised for you to say that I don't go to the mosque. Huh? I'm very surprised that you said I did not go to the mosque. Did I see you? Because I even wait, I prayed here before leaving the mosque. Oh, I didn't see you, Nechi.
Hello, are we still on the lecture hall, please?
Welcome back, colleagues. Welcome back, everyone.
Thank you, sir.
Thank you, sir.
Yeah. I guess
Sir,
we can.
thank you, sir.
Thank you very much, sir.
I guess
Thank
we
you,
can.
sir.
Do we allow 5 minutes? I realize our number has reduced. If you can contact some few, or we should just go ahead. Just 5 minutes. Allow people
Okay, sir.
Or what do you think?
Okay, thank you for the place. Yeah, we'll do that. It's okay, sir.
I just contact colleagues that we are back.
Maybe 2 or 3. Okay.
Everybody knows. And they're waiting for fire alarm.
The timing is okay, sir.
I think they should place it on the platform for them to join us first.
Yes, sir. We have already placed it on the platform, so we are going to just fill on up, sir.
Don't make noise here. I said, with me here, don't make noise.
I guess we can continue now.
Yes, sir.
All right. At least the number has increased immediately. So let's start now. Okay, we're gonna start now, and our focus now is aerobic and anaerobic conditioning. They are the first things we're going to be talking about. In practice,
and this is particular for your group, you are going to meet patients of different categories, and oftentimes we hear about aerobic exercises, anaerobic exercises, and one thing is about how do we administer this, how are they different, and all that. The first thing is there are activities that are meant to boost the condition of an individual that is, let me put it in a lay term, considered to be weak and needed to progress from hospital stay back to the community, particularly for patients who are bedridden for a significant period of time. Sometimes you have somebody being admitted for several weeks, months, and so on in the hospital, and this person needs to go back to the community. Now, what exercise does he need? How do we prepare that individual to go back to the community? And how is he going to regain his fitness? So when it comes to conditioning in such situation where somebody needed to bounce back to fitness level, the most important form of exercise recommended for such individual is an aerobic exercise. Similarly, you could have somebody who comes with a condition like obesity and he needed to reduce weight. Sometimes I wouldn't know whether some of you have encountered a situation where somebody said, I joined that gym with the intent of reducing my weight, but I realized I'm adding weight. It's because a great deal of those who run those gyms are inexperienced. They do not have formal training about the consequences of the type of exercise they expose their patient or their clients to. So in this particular session, we are going to be looking at aerobic and anaerobic exercises. So aerobic and anaerobic exercises are two main categories of physical activities that differ in their energy systems and the way they impact the body, the way they affect the human body is different. So when you expose a patient to aerobic, the responses you see is different. When you expose a patient to anaerobic, you equally have a different response. So what are the differences? Aerobic exercises focus on continuous, rhythmic movements and rely on oxygen for energy. Examples are include running, swimming, jogging, skating, what do you call it? This skipping rope and all that, including football. Those are all aerobic exercises. Those categories of activities are aerobic exercises. We're going to be looking at what are the characteristics that we easily see when somebody is doing this, is engaging this type of muscle. How do we recognize directly that this is aerobic without somebody telling us this is the only exercise? But immediately you see somebody engaging in a particular activity, you'll be able to say whether this is aerobic or anaerobic. They improve cardiovascular health and help in endurance. Endurance signifies being able to do something for a longer period without getting tired. Anaerobic exercises involve short bursts. The period for doing anaerobic is often very short. And of course, in contrast, for aerobic exercises, they take longer duration for someone to complete them. So anaerobic exercises involve short bursts of intense activity. So they are usually very intense and do not rely on oxygen for energy. Examples include weightlifting, sprinting. They enhance muscle strength, power, and anaerobic endurance. There is what we call anaerobic endurance, but it's not as long as aerobic endurance. For example, somebody who did weightlifting and lifted it up and hold it for a short period. For those who watch weightlifting, the individual, after raising it up, they stay there for a period and quickly release the weight. So that's the anaerobic form of endurance. The period they take in trying to maintain that activity level is usually very short. So they call it anaerobic endurance. Aerobic exercises, also known as cardiovascular exercise. When you hear cardiovascular exercise, they are known as aerobic exercise. Some actually call them cardiopulmonary form of exercise or cardiorespiratory form of exercise. Or cardio. Some people refer to them as cardiopulmonary exercises, cardiorespiratory exercises, cardiovascular exercises. They involve activities that require continuous and rhythmic movement of large muscles. So large muscles over an extended period of time. So you do it for a longer duration, and majorly they involve the major muscles, the bigger muscles of your body. During aerobic exercise, the body utilizes oxygen to produce energy. So the rate of oxygen consumption for aerobic exercise is usually very large. So that's why when somebody engages in a long distance walking, he pants for air, trying to demand for ventilation a lot. So here are some key characteristics of aerobic exercise. Number one, the energy source. It primarily relies on aerobic metabolism, which is the utilization of oxygen, where oxygen is used to break down glucose and fat to produce energy. Number two, duration. Typically, aerobic exercises are performed for an extended period. Typical duration is 30 minutes or more at a moderate intensity. So it's not usually a high intensity form of exercise, moderate one. Example, running, cycling, swimming, brisk walking, dancing. Aerobic classes are common examples of aerobic exercises. For those who attend gyms, they know what they call aerobic classes. Benefits. Aerobic exercises improve cardiovascular fitness, increase lung capacity, help manage weight, reduce the risk of chronic diseases, e.g. heart disease, type 2 diabetes, and enhance overall endurance of an individual. These are some typical forms of the benefits of aerobic exercises. Aerobic exercises, also known as cardiovascular exercises or cardio, offer a wide range of health benefits. Incorporating aerobic activities into your routine can positively impact various health aspects of physical and mental well-being. Here are some of the key benefits. Improve cardiovascular health, like I said. Aerobic exercises strengthen the heart muscles, improving its efficiency in pumping blood. This leads to better circulation and oxygen delivery to the muscles and organs, reducing the risk of heart disease, stroke, and high blood pressure. So when you have a category of patients that are trying to manage their hypertension, they are having certain challenges with heart diseases, they are suffering from stroke, and so on. These are the categories of people conditions that benefit a lot from aerobic exercises. And like I said earlier, when aerobic exercise is incorporated into the routine activities of an individual, it benefits the individual physically and mentally. And the stability of that individual becomes better. The health status, the well-being of that individual becomes better when involved in aerobic exercises. It increased lung capacity as well. Ventilation of that individual increases. Aerobic activities enhance respiratory function by increasing lung capacity and efficiency of the lungs. It equally helps the body utilize oxygen more effectively during exercise and during normal daily activities. So these also are the benefits of the aerobic. Increased energy levels. Regular aerobic exercise can increase your energy levels and reduce feelings of fatigue, because the endurance level of that individual has actually increased when in the activities you do previously that you get tired easily, you get fatigued easily. They become so easy for you that you do them and you still have so much energy left helping an individual to stay more active throughout the day. Sometimes you find situation where because within a short time somebody feels sleepy. In fact, sometimes you feel like is something wrong with me. It's because you don't have endurance, and a little activity you see yourself panting, struggling to breathe, and it's because your ventilatory capacity is very low, your lung capacity is very low, your endurance level is very low, and for that reason, if you engage in aerobic exercises, you see yourself improving day in, day out. It lowered the risk of chronic diseases, and typically we're talking about hypertension, diabetes, and so on. Engaging in aerobic activities regularly can lower the risk of developing various chronic conditions, including type 2 diabetes, certain types of cancer, and metabolic syndrome, as well as things like obesity and all that. Let's talk about anaerobic exercise. Anaerobic exercise involves short bursts of intense physical activity. So usually they have it is performed within a very short time. Somebody has completed it, and it is usually highly demanding. It's highly demanding. It's surpassed usually the activity that you want to do. Often is stronger than what you can easily do and stay long on it. Often it's something that you quickly need to finish and drop. It's just like somebody who is asked to come and take a particular luggage or bring it down from a car or a vehicle. You realize that he puts all his energy at once, lifts the item, quickly bring it down. That's a form of anaerobic activity. As a result, anaerobic metabolism, which doesn't rely on oxygen, it utilizes or generates energy from anaerobic metabolism. Key features of anaerobic exercise include the energy source of anaerobic exercise is anaerobic metabolism, where energy is produced from stored glycogen in the muscles without the need for oxygen. The glycogen that is stored in the muscles are the ones being utilized immediately to give the energy. It does not rely on the energy you are consuming through oxygen and so on, or breakdown of glucose that after inhalation of oxygen. It does not rely on that. It utilizes the energy that is already stored in your muscles, and so that you quickly complete the activity, and that's all. Duration anaerobic activities are typically short and intense. They last few seconds, up to around 2 minutes. So you can see it's not an activity that you do for a longer duration. For example, sprinting, weightlifting, high intensity interval training, HIIT, and plyometric exercises are examples of anaerobic exercises. Let me give you an example of even the shape of those who are involved in anaerobic form of activities and those that are involved in aerobic form of activities is equally different. For example, if you look at what is the size of people playing football, do you realize you hardly find somebody who is giant and who is like muscular, let me put it that way, who is extremely muscular as being part of football. But by the time you look at people playing basketball, you realize that because their activity is of a shorter duration, the court they are using is a tiny place. So you see them giant, muscular, and wherever. Or when you want to look at those who are doing 100-meter sprint and those that are doing 200-meter sprint, compare them to those that are doing marathon of longer duration. You see those ones, tiny people, and these ones are huge, muscular, and so on. So because anaerobic activity builds the muscle, make the individual, because you need to store so much energy in your muscle before you'll be able to, even the food they consume is different. If somebody who is a footballer is actually eating the food that belongs to those that are in basketball and weightlifting, that individual will end his career within a very short time. And of course, so it is, and vice versa. Benefit: anaerobic exercises improve strength. Number one, power, speed, and muscle mass. They also contribute to better bone density and increased metabolism in individuals. Benefits: anaerobic exercises improve strength, like I say, speed, and whatever. They also contribute to better bone density, like I mentioned. Boosted metabolism. Anaerobic exercises lead to an afterburn effect known as excess post-exercise oxygen consumption, EPOC. After intense exercise, the body continues to burn calories at an elevated rate to restore oxygen levels and repair tissue, which can contribute to increased calorie expenditure, fat burning, even after the workout is finished. And that is why you realize that after they are done with the activity, some of them have to start moving their body, and so on. Increase bone density, weight bearing. Anaerobic exercises such as weightlifting contribute to improve bone density and reduce risk of osteoporosis. So you can see that when you now ask yourself, how do we use this information clinically? When a woman is approaching menopause, or when a man is entering into old age, oftentimes one of the things we realize in this category of individual is that they will start having reduced bone density. So this information is telling you that if you gradually introduce them to anaerobic exercises instead of aerobic exercises, and again, remember, these individuals are at a greater risk of losing more muscles. And that's why you see an elderly person looking lean. So since they are at the greater risk of losing more muscles, and you now call them to continue to do aerobic exercises, which means they are going to lose more muscles. But by the time somebody is getting older, the bone density is becoming weaker. You understand? And at the same time, he's losing weight. By the time you introduce them gradually into anaerobic exercises, you see them becoming muscular, a lot stronger, and hardly do you now encounter too much of fall rate in the category of the elderly that are exposed to anaerobic exercises. Again, for anaerobic exercises, those who get involved in anaerobic exercise, they have better insulin sensitivity. Anaerobic exercise can enhance insulin sensitivity, making it easier for the body to regulate body blood sugar levels. This can be beneficial for what? Individuals with at risk of type 2 diabetes. Among these category are the obese, are the diabetic persons. Yes, including obese, but we do not often recommend anaerobic exercise for people that are obese. I'm going to explain that later. Even though they are at risk of type 2 diabetes, we do not often recommend the use of anaerobic exercise for people that are obese. I'm going to explain that. Faster metabolic adaptation. Anaerobic exercises allow the body to quickly adapt to the demand of high-intensity activities, resulting in more rapid improvement in physical performance of an individual. Both aerobic and anaerobic exercises offer unique and valuable benefits for overall physical fitness and well-being. Now, let me say something about the issue of obesity and anaerobic exercise. You know, when I started this explanation, I talked about issues around what type of exercise do we give an individual, or you have a situation where somebody say, I'm obese and I went to that gym and I continue to increase in weight. So oftentimes the gymnasium, they expose people that are obese. What they are asking other people to do in terms of lifting weight, in terms of running here and there, short duration exercises and so on, they ask people that are obese to do that. What they don't know is that they are increasing the muscle mass of this individual without necessarily decreasing the excess fat that the individuals have. So when you now have an increased muscle mass plus without burning the fat that is there, you now have double weight. The weight of the muscle, which is usually heavier than fat, and now the weight of the fat. Before you know it, the individual becomes discouraged because he sees himself adding weight, not knowing that it is because he has got increased muscle mass without decrease in fat mass. So definitely the weight is going to increase. So usually what is recommended is that people that are obese, they should go for long duration activity, such as aerobic exercises, which it systematically burns the fat gradually until they have significant reduction in fat. So this is why people that are obese are not usually recommended for anaerobic exercises. Meanwhile, other chronic diseases like the type 2 diabetes can actually go into anaerobic exercises. So this is about aerobic and anaerobic exercises. Of course, there are more to it, but if you have some few questions on this, I will take the questions before I move to the next next topic.
Good day, sir.
Good day.
Please, just about talking about obese patients and exposing them to aerobic and anaerobic exercise.
Okay, go ahead.
Okay. We've also heard that it's very important to actually add both strength training to aerobic exercise, being that if they continue the aerobic exercise, there's tendency that their skin could actually sag over time. Like if they don't add strengthening to it, their skin tend to sag, like when they just continue with aerobic exercise and no strength training. So we've also, like one of the workshops, we've heard that it's important to combine both strength training and both aerobic training, in that the strength training will help to actually toughen or tone the skin while the person loses fat. But then if you just expose them to only aerobic training, they have a tendency of sagging, the skin sagging in long term.
Okay, let me explain this. You see, when you talk about the cosmetic aspect of exercise, you start talking about the strength training. You see, it is okay when we add strength training, but we are talking about where the most of the attention is, particularly in most of the gymnasium you see around. They do not know the difference between aerobic and anaerobic exercise, and what type of exercise do we give a patient. They are unable to distinguish. So when somebody goes to them, instead of that individual to have significant part of the exercise should be aerobic significantly. Because the main reason why that individual is there is to reduce the fat. So if you make the paramount type of exercise you are giving that patient is actually the anaerobic exercise, I'm telling you, there will be no weight reduction. So the most important thing, we say, watch out, what is the goal of that patient? In our first lecture this morning, we said you should have patient-centered type of a therapeutic exercise, where the patient tells you primarily, what am I here for? So if you are going to add strength training, it should be of targeted one, that I have specific reason for including this, but not for it to dominate the activity you are doing. I don't know whether this is clear.
Yes, it makes sense. Thank you very much, sir.
You're welcome. Any other question? So we'll go into balance and coordination exercises. Now, you see, one thing about physiotherapy is that when we talk about exercises, they are always of categories, and they are specifically directed at a particular challenge that the patient is presenting to you. I don't know how many of you have actually encountered a situation like this. You have a patient that came to the clinic for treatment, and this patient was referred to you because the patient is actually suffered stroke. The main reason for referral is that the patient suffered stroke. So therefore, if I ask everybody to describe what is the typicality of the presentation. In fact, let's quickly do this. I need 2 to 3 responses. What are the typical appearances or the typical body structure, let's say typical impairment that we are expecting from a stroke patient that will require physiotherapist's attention? Everybody, right?
Facial palsy, sir.
Gait, sir. Motor impairment.
We have get lost.
Drooling of saliva at times. And then you see him hanging his hand around his neck or chest region.
And we have impaired speech. The patient has impaired speech. Okay.
I would say depending on the location and severity of the stroke. So, but some common ones will expect loss of coordination and balance.
Yeah.
Then sensory impairment like numbness, loss of sensation that affects the limbs.
Sorry, I had a little challenge here. Okay, can people write what are the typical impairment that you are expecting from a case of stroke that will require exercise?
The weakness of the upper limb and lower limb.
Don't say it, just type it. Let me see. I want to quickly see what I will have. Okay, so now from what I have here, I'll wait for 1 or 2 responses more.
Yes, sir, there will be muscle weakness.
Okay, so let's look at some of the responses I have. Flexor dominance of upper limb and extension dominance of lower limb, beautiful. Weakness of limbs, beautiful. Facial palsy, beautiful. Limitations in activities of daily living, weakness of limbs, muscle weakness, drooling of saliva, cognitive impairment, flexor deformity in the upper limb, flexor deformity of the elbow, imbalance, weakness of limbs. Beautiful. I think we can stop like that. Let me tell you why I'm asking you to say this, like something like this. Now, one of the things that we usually encounter, everything that you wrote here is correct. We can find them in stroke. But have you come across a case of a stroke? Joint stiffness is not very common until it is at the late stage of stroke where you have some complications setting in. But joint stiffness is not a common thing in stroke. Okay. Have you come across, how many of you have actually come across a case of stroke where the upper limb is, affected upper limb is actually 5/5. Affected lower limb is 5/5, and the trunk strength is perfect, but the individual cannot walk. How many people? Just type if it is yes for you, type. If it is, let me see how many no, how many yes do I have? Okay, I've got some yeses. No, yes. So there, it seems the yeses are many. Okay, we have some few no's. Good. All right. So let's talk about that. Now, there are conditions of stroke where you will have affectation of, you don't have clear-cut affectation like the usual thing you see about flaccidity of the upper limb and lower limb of one side of the body. You don't see them in certain stroke. And such type of stroke, which I know some of those people who say yes will agree with me that in cerebellar stroke, you hardly have a situation where you have a clear affectation or paralysis of upper and lower extremity of one side of the body. You hardly have that. You don't have hemiparesis or hemiplegia of one side of the body. But clearly, there is stroke in such cases. Now, in cases like that, you assess, you want to check the MMT, you realize everything is intact. But at the same time, the individual does not in any way have, what do you call it? The individual cannot perform all the activities that is expected of the individual. Because of what? Because of the stroke affectation. I'm trying to put back my slide. I don't know what is happening. Okay. Let me try it again. Okay. Let's see if it will pick. Is it, what do I put? How do I say it? Yes, I think it's here. Now, let's talk about balance and coordination. Coordination is the ability to perform smooth, accurate, and controlled movement. Sometimes people get confused about distinguishing, what do you call it? Balance as well as coordination. When it comes to equilibrium of the body being in an equilibrium position, we are talking about balance. But when it comes to performing a task, carrying out a task such that there will be accuracy, smoothness, and total control over the task, then we are talking about coordination. For example, an individual who lifts a cup and wanted to put it in his mouth, but then the hand is shaking, definitely, or to pick the cup, he struggles to pick the cup. And when he lifts it, he cannot directly take it to his mouth. That individual is suffering from problem of coordination. But when it comes to body positioning, the position of the body, whether the upper body or the lower body, if it is not properly aligned, that individual is having challenge of balance. So people should be able to always distinguish between balance and coordination, because some people even use them interchangeably, which is an error in practice. Clinically, it is wrong for you to consider that balance is the same thing as coordination. The execution of fine motor skills and manipulation of small objects in a way that is coordinated, that is organized, smooth, and accurate is known as coordination. Performing gross motor skills, e.g. walking, running, jumping, in a way that is smooth, accurate, and controlled is coordination. Basis of smooth and efficient movement, which often occur automatically. You don't need to start doing it voluntarily. It occurs automatically without you being careful not to make any mistake. That is what we call coordination. The concept of coordination. Coordinated movement involves proper sequencing and timing of synergistic and reciprocal muscle activities. They require proximal stability and maintenance of posture. So the upper part of the section of the body that is supposed to conduct the activity is stable to allow the distal part of the body to be able to conduct the activity. So there is this sequential segmental ability to be able to conduct an activity. When you now have a situation where there is no segmental division, we call it mass movement and affectation of the muscular synergy, then that is an aspect of incoordination. Coordination refers to using the right muscle at the right time with the right intensity. So you use the muscle that's supposed to be used. You have a situation where you don't have to compensate with another muscle. It's just like when you say, lift this cup and take it to your mouth, and the patient has to be lifting the shoulder. What is the relationship of putting a cup in your mouth and your shoulder? So in that regard, there is a mass movement and there is no segmental division of movement. The concept of coordination includes balance too. It also includes balance, but then it is not balance. Let's talk about balance. This is the ability to maintain equilibrium. That's the first thing. The ability to maintain the center of gravity over the base of support. Vestibular dysfunction, visual impairment, or diminished proprioception can all interfere with your balance. So the vestibular dysfunction, majorly, the vestibule, which is there in the ear, when it is dysfunctioned, can actually interfere with your balance. The visual acuity of an individual can interfere with the balance. The proprioception, which is there in the joint, can also interfere with the balance of an individual. So which means some part of the concept of balance actually are musculoskeletal. Physiological basis. The somatosensory system provides information about the relative location of the body parts, and proprioception reflects the perception of the static position. That is positional sense. So these two, somatosensory, which is the body parts, as well as the proprioception, which is the joint position, they are important at static position to determine the balance of an individual. Kinesthesia refers to the position during movement. Information arises from peripheral sources, e.g. joint capsule, soft tissues, to determine the kinesthesia. So at the dynamic situation, that is when the individual is in the move or is moving, kinesthesia is the major determinant of balance. Sensory receptors, information to the medulla and brainstem through dorsal column media, lemniscal pathway, are also very essential when it comes to the aspect of balance. This is neurological. We may not need to go too deep about that, except if probably in future you want to have total understanding of the pathway of balance in the brain. We can schedule a lecture for that one specifically, and as well talk about cerebellar lesion and all that. This information will assist in coordinating eye, head, and neck movement to stabilize the visual system, in maintaining posture, muscle, and stiffness in the muscles, coordinate, and also to coordinate movement patterns. So we need to understand somatosensory system, the kinesthesia, the sensory receptors, all together. By the time we bring them together and we understand the vestibular system, we understand the visual acuity of an individual, all these together, when we put them together, they are the one that give us a better understanding of positional sense, muscle tone, and stiffness in the muscles. All of these together, when they are affected by disease factor, they can interfere with the balance and coordination of an individual. Now, talking about the visual system, through the retina, the optic nerve and thalamus provide information about the position of the head relative to the environment and orients the head to maintain posture. Now, if any one of you can remember what they call the writing reflex, usually what happens in the writing reflex is that immediately you distort the position of the head. If you take it to the back, the entire body follows. If you take it to the side, the body follows. So it's telling you that because why is the body following? Because the vestibular system is being moved. But this information, how does it happen? It is the retina through the optic nerve that promote or take this information to the thalamus to determine the relative position of the head in relation to the environment, in terms of where is the head going? Oh, let us follow. If the head is leaning back, it's going forward, the entire body follows. If it is side, it follows. If it is back, it follows. The vestibular system provides information on orientation of the head, that is the location in space, and on acceleration, that is the way it moves. Any movement, including weight shifts, to adjust posture, stimulate the vestibular system. Immediately you adjust your position, it stimulates the vestibular receptors, vestibular nerve, cerebellum, and spinal cord for postural control. So it goes from that vestibular nerve straight to the cerebellum and then back to the spinal cord for postural control. So this is essential for us to understand. Balance requires for a person to maintain a position, to stabilize during voluntary activities, needs trunk and head control. So if an individual does not have a proper trunk control, does not have head control, does not have neck control, how do you expect that individual to maintain balance? And that is typically what you see in pediatric cases of cerebral palsy. No neck control, no head control, no trunk control. To react to the external perturbation, visual and auditory awareness for cognitive skills, we must have what do you call it? Intact control over the head, the neck, and the trunk. Effective and efficient coordination among multiple sensory, biomechanical, and motor systems is what ensures ability to maintain balance and coordination. Causes of impaired balance. So what are the things that actually may cause impairment in balance, injury or disease to the eye. So if the eye is affected, definitely balance will be touched. Inner ear affectation, which is the vestibular system. Peripheral receptors that are supposed to take the information to the brain, if they are affected. Spinal cord injury, head injury affecting the cerebellum, basal ganglia as well as cerebrum, can equally affect balance. Damage to proprioceptors, peripheral nerve injury, injury or pathology of the hip, knee, ankle, and back have been associated with postural sway and decreased balance after muscle atrophy, degenerative disease or degenerative joint disease, and as well as total joint replacement, particularly these arthroplasties, hip arthroplasty, knee arthroplasty, all of them can interfere with balance, which because of what? Basically because of affectation of proprioception. Causes of impaired balance, lesions of the cerebellum or basal ganglia, like in the case of Parkinson's disease, Huntington's disease, cerebellar tumors, lesions produced by tumors, cerebrovascular accident, typically the stroke that we mentioned, causing visual field losses, changing the spatial orientation and altering balance. All these can happen in this condition. Age appears to affect all aspects of the stability triad, somatosensory, visual, and vestibular. So if somebody becomes older, all these, the triad of of stability are actually affected. As 30% of the person above 60 years old have experienced a fall, and about 1.5% repetitive fall. Is it okay? About 15% of them can have repetitive fall. So you can imagine. And why are they having a fall? Is because the triad of stability are affected: somatosensory, visual, and vestibular as somebody gets older. Medication could cause dizziness. There are certain drugs that somebody can take. For example, I believe when people are having flu and you take medications related to flu, you are usually even advised, written on the medication, that don't drive, don't do this, don't do that because of taking that. Drowsiness or sense of weakness, like antidepressants also have those quality or characteristics. What about treatment? Remember the balance problems, e.g. neuromuscular impairment, musculoskeletal impairment, lack of stability, sensory impairment, cognitive impairment. So now, if the impairment is actually musculoskeletal and it is not, which is basically somatosensory in this regard. If it is musculoskeletal, we look at somatosensory aspect. That is a somatosensory aspect. So tackling that particular condition at the level of a somatosensory level will help you to be able to manage the condition. If somebody is having OA and you treat the OA, and the OA, the individual is cured of this OA and have significant improvement in the OA, then the chances of that individual having problem with balance will reduce because you've attacked the somatosensory impairment leading to the imbalance. That's the in the neuromuscular impairment, musculoskeletal impairment, sensory impairment, all these and cognitive impairment on that. So the main cause of the imbalance, or what do you call it, either the imbalance or incoordination, you have to know the main cause so that you can address the case from the source. Physiotherapy, always one of the things that we try to do is we care about what is the source of the impairment. So we do not treat symptoms. If somebody is having pain, our major focus is not the pain, it's what actually is causing the pain. And we address what is causing the pain. We are unlike other professionals that what they manage is the symptoms, but our focus is the impairment, and let us address the impairment. And that is why you find out that when some colleagues, some health professionals have challenge in managing patients and they don't know what to do, they will say, just refer the patient to physiotherapy. Because our assessment goes down to the impairment level. We do not start with the disability of the person or the participation restriction the individual is suffering from. We are concerned about the impairment and the source of the impairment. Use stable, hard, rigid, and even surface when you are going to treat your patient. Then progress to uneven surfaces. So at the initial stage of treating balance, try to get a place that have an even surface and the place is good and the patient is not going to be scared of walking around that side. Start with that, then progress subsequently to to surfaces that are uneven. Begin with weight shifts. In the case of trying to treat a patient, unfortunately, this is a virtual meeting. We would have been demonstrating this directly so that people will have a good grasp of what we are trying to explain. Begin with weight shift. A number of times what happens is that people are more concerned about seeing their patient walking without necessarily focusing on some other elements that will aid the ambulation of the patient. Unfortunately, when patients start walking and you did not care about the perspective of balance and coordination, if your patient falls, you've actually discouraged the patient from partaking in anything that has to do with ambulation again. And that is why after the first fall, you realize that many patients hardly recover again because they are completely apprehensive of making another effort. So we should co-opt aspects related to balance and coordination into our management plan. So you cannot just focus on, let me make sure I impress the family, let the patient start working. That should not be your focus. Your major concern is the patient and how the patient will recover and be happy with himself. But by the time you cause a trouble to the patient by initiating ambulation, and the patient is so confident that I'm able to work, but the patient does not know that he doesn't have balance or coordination, and at the end of the day, the patient falls. You may discourage the patient from making further attempts in working. As the patient improves, increase compliance of the support surface as much as possible. Dosage, environment. Train the environment with a real stimulation he will encounter when leaving the clinic. A number of times we try to treat patients in the clinic and our focus is the patient is working, the patient is doing this, the patient is doing that right in front of us, and we are all happy and the family members are equally happy. But there is no projection about what is the patient going to meet after reaching the community. Hardly do you even have situations where physiotherapists are asking questions. Tell me the characteristics of our house, the nature of your house, where is your room located? How do you think you will be able to manage the situation when you get home? Some of us have these staircases that are for treating patients in our clinics. And we only ask patients to go on it because we want them to be active. Some patients do not need that thing completely because, yes, they can improve in ambulation, but it is useless when they go to their houses, there is nothing. They don't have any staircase to climb. Why are you wasting their time? Focus on what they need, find out the characteristics of their houses, and train them according to the situation they are going to meet in the community. This is a number of times this is missing in our practice. And we have to inject things like this so that our patient, by the time they get home, they find it a lot easier. Sequence, progress from simple to complex, involves changes in mode, posture, and movement, and as well. So the thing is, when you want to start training patients, start with simpler things that the patient can achieve, so that usually when you start with simpler things, it is usually very motivating to the patient because the patient have more confidence that I'm able to do this. So by the time you now ask him to do another one, he will make an attempt. But you now have a situation where somebody is making prescription. This patient, you are not even making, look at the other patient, he's doing it. You are not doing anything. And even the family members start feeling that their own patient is not ready to recover. The patient is just there to punish them. Look at how what others are doing, and he is not making effort. Forgetting that the level of impairment may be different, the circumstances and the mental status and emotional status of the patient, the cognitive status of the patient may be different. Mere seeing physical appearance does not necessarily explain the situation of the patient. So all these must be factored into our plan for treatment, and this will significantly improve our practice. Use external feedback, for example, e.g. mirrors, which allows feedback about position. My leg, your leg is not standing well. Let him see it clearly. Let him see it on the mirror. No, your facial palsy, look at how your mouth is shifting. Move it to this side. Try to write your position. Little by little, these patients, by the time you are consistent, the frequency is usually a key thing. Frequency as well as amount of repetition are the major thing that push patients to recover faster. Yeah. So this is it about the dosage. So what of materials? We can use balls, foam rollers, foam surface to provide uneven and unstable surface and to provide a variety of balance experiences. Train sitting balance, trunk stability, weight distribution on chair, table, or therapeutic ball. Balance beam, lines drawn on the floor using like the Frankel's exercise, balance board, like the wobble board, and scales can be used for balancing training. All these are, when you put all these items together, you look at patients that can actually benefit from them and implement, make them go through these items because they are there for them to be used. Some places have wobble board, but nobody even remember the last time anybody even touched it. In fact, when you have young physiotherapists, they don't even know that it is useful. What is this thing for? I've never seen anybody going on it. So these are key things, and they are very, very important when it comes to managing patients. Contraindication. Training is contraindicated for patients with cognitive impairments, as the patient may be unstable to understand the purpose and mechanics of the activities. Precaution. Choose activities appropriate for the patient's skill level. Start by simpler and safer tasks, then progress gradually. Eliminate obstacles or unsafe objects while the patient is training. A gait belt, hand contacts from the clinician, parallel bars, or stable external object should be used for the patient. When you use that, it gives the patient confidence and it motivates the patient that you are not going to fall, so you can continue. We have 15 minutes left. I will take questions. The remaining part of this, whatever, I may not be able to exhaust them, the understanding may not be there. So I would prefer to take questions than to continue with the slide. Comments, questions, and all that, you can pass it, and let's before we close the session. Thank you very much. Your comments, your questions, where do we need to improve in presenting this thing so that you guys will understand it better? I know some part of it may be too elementary for some of you, but what I decided in this is to forget the fact that people have gone through quite a number of things, but to take it from the root. When we want to come with advanced classes, people will be able to relate with it. So can we have some questions? You can, if you don't want to talk, you can type in your question. And if you want to talk, you can go ahead and make your statement.
So, yes, sir. Good evening, sir.
Good
Thank
evening.
you for the lecture. Thank you for the lecture, sir.
Thank you.
I want to suggest something. If there's a way you will create a video, like a video in the slide, maybe when teaching on this kind of topic, there will be a video to show the kind of exercise and how to do it.
Okay, yes, in future, definitely, is important, so that we can give some few demonstration, right? Yeah.
Just like
And equally, I think probably I will discuss it with them if we can insert some few videos for people to before sharing the slide. Yeah.
Yes, sir. And again, you say something about how to flex the ulnar and radial bone. I am still confused about that.
How to do what?
There's any way you can put more light on it.
I don't understand. Please,
Flex the
question again.
ulnar.
How to?
You talked about flex the ulnar and radial bone.
How to do what?
In the flex the ulnar and the radial bone in the hand.
Flex the ulnar and radial bone. I think you didn't get it right. I think you didn't get it right. I don't think I make any statement like that.
This session, the last session, I think I didn't get it right there, sir. Because there
Pardon?
was network issues. There was network issues then. I didn't get it right. So I'm just trying to figure out the statement.
I don't think that is the statement I made. But what actually is your question?
No, I just throw light on it. So now, how to I talked about you said it's not your statement, sir. The inflection of the ulnar and radial bone. So I am still confused in that part.
The problem is I didn't make that statement, so I don't know where you get it from.
Hello, sir.
Yes.
Yes, sir. I think from the slide, there was the slide you pictorial representation of the radium ulnar, which was flex.
Was it in the previous slide or the one I just presented now? Pardon?
The first presentation.
Yeah. Yes.
Yes, there was a picture which shows the radial, which one was flex. I think that was where it stopped.
Okay. They are not. It's not reciprocal. I mean, it's not simultaneous. Is that clear?
Okay, sir.
It's not simultaneous.
Yes, sir.
It's not that they are being done at the same time.
Yes, sir.
I hope it is clear.
Yes, sir. So, in aspect, is there anything like flexing them, or apart from pronation and supination exercise,
Yes.
is there any other again to move the ulnar and radial bone?
Ulnar and radial bone, majorly to move them is supination and pronation. They move on top of each other when you do pronation and supination. However, when you now want to flex the elbow, you also have movement, particularly of the radial bone. Is that very clear? Because it is the radial bone that is attached to the humerus. So we also have the movement of the radial bone because of flexion and extension of the elbow. But in terms of movement relationship between radial and ulnar, it only takes place during supination and pronation. I don't know whether this answers your question.
Yes, sir.
All right.
Yes, sir. Yes, that's my question. I was just confused, a bit confused.
It's all right. It's all right. It's all right.
Thank you, sir.
Yeah, pleasure. Any other question?
So I don't have question, but I have an appeal I want to make.
Okay.
I want to appeal to the organizer and your humble self, sir. They should please make the slide available to every individual that participates in this section. Because I believe the goal of this section is not just to listen to you and go away and have the certificate. but rather
Definitely not.
to have the knowledge so that the knowledge will be purposeful and impactful. But it's very it bemoves me sometimes that after this you didn't get slide, and when the application comes, or at times you need to consult some of your material as to broaden one's knowledge. The materials are not there to help out. So please, I want you to kind of liaise with them and then do it in a way that it will get to every individual without any hindrance or hindrances. Thank you, sir.
I will surely tell them to circulate it. For me, the basis of this session is actually to broaden the practice of physiotherapy. If you actually notice the pattern of giving the lecture, there is a total interest in making sure that people understand each and everything. It's not about rushing through the slide. If it is rushing through the slide, I would have finished whatever I have in the slide. But the intent is for people to be able to have something. I don't like it when people attend any session I present and they have nothing to take home. It is completely a waste of time. So I will notify them that there is a demand for the slide and they should make it available.
Thank you, sir. Thank you for speaking in the language that everybody understands, because you spoke a very simple English that everybody will understand, sir.
Thank you. It's a pleasure.
Yes, in addition to what he said, I must thank you for the detailed illustration and the explanation to all the things you've taught us. I really appreciate. But just in addition, the certificate of a thing, because some of us who participated really need certificates maybe to authenticate some of our licenses. So I don't know if it will pleases you to maybe fasten or facilitate the time in which it normally stays, because the other time we did it, it's still longer than a week before we can be able to get it. So that certificate is still important if you can be getting it early.
The thing is, you see, I am only a facilitator, but then the way you talk about it, I will actually talk to them about getting the certificate ready. I'm only invited to facilitate this, but then complaints that like this, I will surely pass it to them.
Sorry, Prof. Let me just come in here.
Thank you, sir.
Okay. Thank God, Dr. Samani, you are there.
The certificates are always already given on time. The only time we have challenges if sometimes people do not fill the Google form on time. And if people doesn't fill the Google form on time, when we submit the list to the certificate production places, we have to wait to do it in batches. That is why sometimes they take some time, because we don't submit in piecemeal. If we gather the list from the Google form, we submit. So if somebody fill the form late, we have to compile the latecomers and then submit. But it will be given on time, be rest assured, the certificates.
So let me just add one thing to that. Everybody must log in and make sure that he fills his Google form today.
Yes.
If you do that today, you are not delaying anybody.
Yes.
Pardon?
I have a question, sir. Back to the lecture.
Go ahead, please.
So please, I want you to shed more light on the weight gaining on aerobic exercise. I just want to brush it up, sir, a little bit about weight gaining.
Okay, when it comes to anaerobic exercise is what I talk about weight gain. Aerobic exercise is for reduction of weight. So which one do you want?
The weight
or
gaining.
Both,
sir.
All right. So when it comes to aerobic exercise, it is of a longer duration. Minimal weight is attached to the activity. For example, in anaerobic exercise, we do not lift any weight. It is not a form of resistance type of exercise. There is no resistance attached. Let me give you an example. Somebody who goes to the gym and he wanted to reduce his weight, and he was asked to go on, treadmill. You know, treadmill, we can decide to make it inclined. I don't know whether you understand what I mean by inclination in treadmill exercise.
Very well, very well.
So when you make it inclined, you see that the individual is not only exercising, he's equally trying to overcome a particular resistance.
Exactly.
When somebody is using a treadmill in an inclined position, that person is going to have additional weight because he's going to have increase in muscle bulk.
Okay.
So it is when somebody is using bicycle ergometer and they put so much resistance that it takes time for him to be able to wheel it. Are we together? So that individual is also going to have increase in muscle bulk. So when we say weight gain, we are not directly saying there will be weight gain. We are saying there is the increase in muscular strength as well as bulk of the muscle. So if the muscle increases in bulk and the individual is also obese, when you put the weight of the fat and the weight of the muscle together, that increases the weight of the individual. Instead of the individual to have reduction in weight, the person will be complaining that my weight has increased. I don't know whether this is clear.
It's very clear, sir. That was where the confusion was. Very clear now, sir.
All right. Thank you very much. Any other question?
Yes, sir.
All right. Thank you. Thank you very much for the session. Thank you for attending. We have.
Waiting, maybe get run away now.
Waiting, God to tell you.
We have
So, God willing, we
just vanish.
All right.
Question.
I think we can close the session. Dr. Samani, please, you can close the session.
Question, sir.
Question? Okay, this will be the last question I'm going to take. All right, go ahead.
Yes, sir. Thank you for your presentation, sir.
Yes.
My name is Olani from Lut.
All right.
When you have been treating a stroke patient that has equal affectation of both upper and lower limb in one side of the body, we notice that the lower limb recover quickly than the upper limb. What happened?
This is neurology, but let me quickly answer that.
Thank you, sir.
You see, the representation of the body parts in the human brain, particularly in the cerebrum.
Yes.
It is represented by the amount of activity that body part is used for.
Okay, sir.
Now, between your hand and your leg, which one do you use most?
The hand.
So the size of the hand in the brain
the hand,
is
sir.
bigger. Eh? Are you
in
listening?
the homunculus. Yes, sir.
The size of the upper extremity in the brain is bigger than the size of the lower extremity.
Yes,
now,
sir.
Let me give you a layman's description. If your son is carrying, let's say, milk, and the milk splash in a smaller place, or probably, let's say, sugar, and you want to pack the sugar and it's in a smaller place, and a case where the sugar splashes on a bigger place, which one will be easier for you to pack?
The bigger space.
How can the bigger space be easier to pack?
Because you have space to pack it up.
You are making mistake. The sugar will spread in a bigger place, but in a smaller place it is constricted. So you
it's constricted. You have smaller area.
Yeah, because you have smaller
area to pack it.
So then you may probably recover the whole of your sugar in the smaller place compared to the bigger place. So what is happening in such kind of a case is that the lower extremity is small. So recovery of the lower extremity is faster than the recovery of the upper extremity. This is the lay way I can easily put it for you to understand.
Okay, sir.
Is it clear?
Thank you very much. It's cleared. I knew little about that before, but I want to confirm whether it is true. That's what I read somewhere.
All right.
Thank you,
very
sir.
much. Okay, Dr. Samani, can you close this session, please?
Thank you, Prof. for doing justice to the topic, and we also thank the participants for attending. And certificates will be issued on time, and then the slides will also be made available. Thank you all, and see you next time. Bye-bye.
Bye, everybody.
Thank you very much, sir. Thank you. God bless. We really appreciate it. Thanks.
Bye, sir.
God bless. Bye, sir.
Oluchukwu.
Well done, sir.
Oluchukwu. Oluchukwu.
Well done, sir. Well done, sir.
How far now?
I did find you.
This is a very
How's
wonderful today.